afternoon, good evening, depending on which part of the world you are in. We welcome you to this first Asian EUS group webinar on interventional EUS. I thank all of you who have joined this meeting. We have had excellent response, about 660 endoscopists, endosonographers. Some of them are very senior and highly respected, have joined this meeting with us. And this is actually bigger than any of the meetings that I have ever conducted. And I can tell you, I have done some big meetings in the past. So this is great. Thank you very much for sharing your time with us. We have 52 countries represented today in this webinar. And I have a list of all the people who are here, but I don't think I'll be taking each one's name, but I do want to quickly go through the names of the countries that are present today in this webinar. So just give me a quick 1 minute. So we have number one, Colombia. We have Professor Lazaro Arango with us. Thank you very much to Professor Lazaro and to the ACED for helping us out with this. We have lots of representation from Colombia and from South America because of your efforts. Thank you, Professor Lazaro. Quick list: Algeria, Argentina, Australia, Bangladesh, Bolivia, Brazil, Cambodia, Canada, Chile, China, Mexico, Ecuador, Egypt, France, Greece, Hong Kong, Hungary, India. India has the largest representation, of course. Indonesia, Iraq, Italy, Japan. Japan has a big representation. Korea, Malaysia, Mexico, lots of people from Mexico. Morocco, Myanmar, Netherlands, Nepal, Nicaragua, Norway, Pakistan, Peru, Philippines, Poland, Qatar, Romania, Saudi Arabia, Singapore, Spain, Sri Lanka, Taiwan, Thailand. Thailand has a big contingent.
Uh-oh.
Program.
Meeting. It's a very, very focused subject, EUS-Guided Gastroenterostomy, but I'm happy that you are here, and I know you are here because of the faculty that we have with us. These are all very, very respected and renowned people who have done a lot of work in this field. So may I introduce our faculty who will be helping us today. First of all, Professor Takao Itoi is with us from Medical University of Tokyo. Hi Takao, welcome to the meeting. Takao is, I don't have to tell anything about Professor Itoi. He published a very significant paper in the gut on the Epass technique, and not only EUS-guided gastroenterostomy, but he has published in a large number of other areas pertaining to EUS. And Anthony Teoh from the Chinese University of Hong Kong with us. Hi, Anthony. Anthony has been publishing furiously on all topics, including GJ, and he has got a sort of reputation for being a very, very scientific mind, analytical mind. So the topic that we have given Anthony reflects that. We have two other friends, colleagues who will be joining us. Professor Mouen Khashan, he is from Johns Hopkins, has published a comparative trial. Hi, Mouen. Mouen is here. So hello. He has published a comparative study of EUS-GE and enteral stent. We would like to hear from him his technique. And then We have Professor MP Miranda. He'll be joining us soon from Valladolid, University of Valladolid, Spain, who again has done big work in EUS-guided gastroenterostomy and study and published comparative trials. So now, before we start with Mouen's lecture, I will just give you the format of what is going on, now what we are going to do in the next few hours. So this is a monothematic webinar on management of gastric outlet obstruction with the lumen opposing metal stents. We will also discuss the other modalities, enteral stents, a little bit of surgical GJ, which technique is better. We have multiple techniques for you to see. Each has their own technique of how to do a surgical gastroenterostomy, and then how does it compare it with other existing techniques. Anthony will be telling us that. So we learn the various techniques, we understand the current data, and the format is we will have lectures. So the lectures will be 20 to 25 minutes, followed by questions. So I would request you to type your questions in the Q&A. You will see Q&A at the bottom of your screen. Just click on that and type your question. Please ask a lot of questions. Some of our panelists are very busy, so they may not be available afterwards. So please ask questions immediately after their lecture, if possible. So Q&A, then there will be after the lectures end by Professor Miranda, and at the end we will have few questions on the live demonstrations also. So without much ado, welcome you all of us, all of you again. I will ask Mouen to start his lecture on how I do EUS-guided gastroenterostomy. Mouen.
Okay, great. Can you guys hear me well and see me well?
Yes.
Okay, and you have this full screen, right?
Yes.
Okay, excellent. So it's a pleasure to be here. Thank you, Vinay, for inviting me. This is a great symposium, and the focus topic is a great idea. So congratulations. I'll be after my lecture. You know, I'm very interested in this topic, so I'll be in and out between my endoscopy. So I have two cases to show. These are live cases. So so that way we'll show you how we do it in real life. And I'm happy to take questions after each case. Vinay, if you feel I have to stop, pause during the video, please let me know and I'll pause and I'll take questions.
Sure.
So this is a case that I did last year in Milan. It's a patient with ampullary adenocarcinoma. He's had multiple chemotherapy sessions. CT showed disease progression, and they tried to do a duodenal stent, and it was unsuccessful. So I start with the patient on their back under fluoroscopy, and here's our gastroscope situated just proximal to the obstruction. So if it's at D1, D2 here, we're just in the duodenal bulb, and there we see the biliary stent. So now we're using a 60 cc syringe, and we'll inject contrast. We're not putting any air. And now under fluoroscopy, you want to make sure the contrast is going the right direction. Nothing is coming back up. So after we fill the small bowel, we know it's good. We give glucagon. We want to give a small bowel paralytic so that this dye stays in the small bowel, and it actually does. I like to inject about a total of 500 cc's. It's a mix of saline, contrast, and methylene blue. Here you see some methylene blue combined with contrast. The idea is to distend the small bowel as much as we can, push the air out, and have a dilated small bowel loop very close to the stomach. You see this scope here is looped in the stomach. So do you know this is the stomach here? And we know we're gonna have nice dilated loops close to the tip of the EUS scope when we place it. So here I'm continuing to inject and looking at the small bowel. Here's some a little more contrast. So if we're injecting saline, you know, I mix them with saline, etc. I like saline instead of water so that we don't cause hyponatremia. So again, a total of 8 to 10 syringes. So that's about 400 to 500 cc's. I like to dilate multiple small bowel loops. That gives me more options to target with the EUS scope. Once we feel we're good, you know, I give a milligram of glucagon before I start injecting. And then I give another milligram when I'm changing scopes. Because, you know, we have to remove the EGD scope and put the EUS scope. So here I'm being a little even more generous than usual with the contrast. I think we have adequate dilation. So here we're pulling the gastroscope out. So your team has to be ready. So we can't now go get the EUS scope, you know, from storage. The EUS scope has to be ready. You see the stomach clean before you start your endoscopy. You know, you have to clean the stomach if there's any food debris. If any of the contrast material came to the fundus, also that has to be suctioned. And that's why initially when we look with fluoroscopy, you want to make sure most of the contrast is going forward and not coming backward. You don't want to spend 15 minutes suctioning contrast from the stomach. So now this is the EUS scope that was already, that was ready. We're gonna push it down to the stomach and we wanna approach one of the dilated bowel loops under fluoroscopy. And sometimes you actually can indent, so touch the small bowel loop with the scope. You move it. Once it moves, you know you're indenting it. You're right there. But more importantly is use fluoroscopy to direct your scope towards a dilated small bowel loop, like that. So turn the other way. Here you go. And now once we're like this, we turn into our EUS vision. And look for a dilated small bowel loop. So uniformly, you're going to have a dilated small bowel loop close to the stomach. That's a little harder in patients with upper surgical anatomy, but with standard anatomy, you're always going to find a loop of stomach dilated and close to, loop of small bowel close to the stomach. So of course, you want to use Doppler to make sure there are no major intervening vessels. Small vessels are okay. Vessels a little far are okay. So, but you want to be careful. Even if there's like a vessel like you see here, there's a vessel there. So it's okay to go next to it, but you gotta be careful if you not to dilate the stent at the end. If you dilate the stent at the end, you're gonna shear that vessel. So here's the technique I follow. This is a 19 gauge needle, and I call it the finder needle. So now we wanna puncture the small bowel loop with a 19 gauge needle and apply suction and make sure we're gonna get blue dye. Once you get blue dye, you know this is the jejunum and not the colon. So there have been reports of inadvertent gastrocolostomy. So this is an easy step, takes 2 minutes, and that way we ensure we have the right target. The transverse colon is right there where we're working. So you may puncture a dilated fluid-filled transverse colon without knowing. So in my opinion, this finder needle technique is essential. So now we have a 15 millimeter or 20 millimeter hot axius. This is the direct technique, so we don't push a wire. So if you push a wire now, it tends to push the small bowel loop away from the stomach wall. So make sure the stent is secured well on the scope. You don't want it to be wobbly in the middle of the procedure. Sometimes it takes some work to secure it at the hub. And now we're continuing, we continue to look at the same bowel loop to make sure we're not changing vision. And now we are perpendicular to the jejunum. Very important, we don't want to go tangential. So everything is ready. And now it's a slow puncture using heat. This is not an FNA. We don't want to push the small bowel away from us. Let the heat find its way into the small bowel. It's an excellent, the cautery tip is really excellent and smooth. It goes very nicely, but if you jab it, you're gonna push it away. So now this is a 15 millimeter axius. we deployed the first flange in the small bowel under EUS. We pulled it a little bit to oppose the small bowel loop to the stomach. Now we deploy the second flange in the scope. And now will be the only time where we switch to endovision. So once we switch to endovision, you want to back the scope away, a little away from the stomach wall to give space for the second flange to open up in the stomach. So you kind of exchange a little, back up the scope, push the sheath out, back up the scope, you should push the sheath out. And now you see the stent. Once you see it, you just push it out and it deploys. Once you see this blue dye, it ensures you that you are in the right place, getting like just a contrast study. We give 1 dose of antibiotics before the procedure. These patients do not need antibiotics. I do not dilate the stent. The stent within 24 hours dilate. I've had issues with dilating the stent. There's really no rush. What we do is these patients are not nil by mouth. The first day, we admit them to the hospital. The second day, they're on a liquid diet. If they tolerate that, we advance to a low residue, low roughage diet, and they go home on that. We have some experience with a 20 millimeter stent. The way I think about it now, if I have a nice dilated small bowel loop, I'm comfortable going with the 20. If it is not that dilated, it's not perfect, I use the 15. But we've noticed that the 15 actually, the patients are able to tolerate almost a normal low residue diet. And we send them home, not on antibiotics. We tell them advance to almost a normal diet, and really that's it. Doesn't affect, if the patient was on chemotherapy, we ask them to restart chemotherapy in a couple of days. There is no peritoneal contamination, seeding, or anything like that. So that's the technique I use, Vinay.
Vinay, your phone.
Can't hear
Microphone.
Unmute.
Yeah.
Microphone, yeah. Can you hear me now?
Yeah.
So, Mouen, can you hear me now?
Yes, and I do have another video if needed, as I said.
No, of course it is needed. Our questions have already started coming. So I think what you do is show your second video, and then we will take all the questions together. So please go ahead with the second case.
Okay, the second case, do you guys have it now? Can you see the case?
Yep.
Yes, please go ahead.
Okay, good. Okay, so here we're just gonna make it a little faster. So this is a patient with a duodenal stent that's obstructed, advanced pancreatic cancer. Just gonna make it a little faster. And here's the stent. So we're able to reach the proximal aspect of the stent, and we inject here through the stent. So glucagon, as I mentioned, and filling the small bowel with contrast and methylene blue and saline under fluoroscopy. Generous infusion. This is the methylene blue. And then quick pulling of the EGD scope, suctioning any fluid there so that it doesn't confuse you during the procedure. And now this is the finder needle in a dilated jejunal loop. See how nicely dilated and close to the stomach it is. You actually have multiple options here. Usually you do. And now you have the hot axius perpendicular to the jejunum. Slow push, not a jab, using cautery to find and push it all the way in. Deploy the first flange. Pull the jejunum towards the stomach. Switch into end of view here after deploying the second flange. So we see this small view here, endo. So hopefully we'll start to see the stent a little bit. So here I'm pushing the axis out of the scope a little bit while pulling my scope away from the gastric wall. I want to give space for that flange to open. And now we're seeing the stent a little bit, and then you go ahead and push it out completely, and it opens right away. So here the procedure is done. You don't have to dilate, you don't have to do anything. Okay, Vinay, that's it.
Dr. Vinay, you need to unmute your mic.
Yeah, can you hear me now? So, Mouen, thank you very much. That was a fantastic demonstration. You made the technique look very, very easy indeed. The questions are there for you from people. Dr. Siddharth Srivastava wants to ask, how do you follow up these patients?
Yeah. So these patients are, one day in the hospital, they go home and on a normal diet, just low roughage. And we see them as we see any other patients. We check on them on what type of diet they are on. There is no need for follow-up endoscopy unless patient has recurrent symptoms. These patients are followed up within our system. This is a big pancreaticobiliary center. So every one of these patients is undergoing treatment at our center. So the follow-up scans, follow-up clinic visits, everything is within the system. So that's very helpful. But we don't do an endoscopy just to follow up on the stent patency. We go with symptoms.
Okay, so purely by symptoms, no routine follow-up otherwise, once the patient goes home.
Yes.
Dr. Girish Balaraju is asking, which place to select for puncture? I mean, greater curve, antrum, lesser curve. Why not use a guide wire? So, Mouen, a lot of these people are not doing GJ. So, little basic questions are understandable. Please.
No, these are very good questions. So the first with the guide wire, as I mentioned, actually, if you look at multiple papers, including Takao's paper in gut, Takao is here and he can comment on it. He published a prospective trial of 20 patients. The technical success was in 18. The two technical failures at that time were due to likely wire pushing the jejunum away from the stomach. So you have a very loose peritoneal organ that's very mobile. And when you try to push a wire, you're pushing the jejunum away. I know, when you start, you always feel more secure if you have a wire. But the wire potentially can do more damage than good in this case. And I've actually had one also stent misplaced, and when I reviewed the video, this was exactly the problem. Once you're comfortable with using the cautery tip stent, you really have to be comfortable. This is not a 10 centimeter pseudocyst that's fixed. This is not a gallbladder. This is harder. This is a small mobile organ in the peritoneum. So once you're comfortable targeting this small organ with fine movements, so if you're perpendicular to the jejunum and slow push using cautery to access it, that allows you to avoid the use of a guide wire. In terms of where in the stomach, I am not looking endoscopically to see where the stent is going to be deployed. This is not going to be the antrum, I always think the antrum and these axial stents are not friendly to each other. Placing a lumen opposing stent in the antrum, it's a big problem. They get buried, food impaction. So GJ does not happen in the antrum. Just anatomically, it's usually in the gastric body. But whether it is greater curvature, lesser curvature, what I care about is the optimal EUS position. Your scope has to be in comfortable position. The stomach and the small bowel loop have to be opposed, and you have to have a perpendicular angle to the small bowel. You want to have no chance for misdeployment.
A question.
Great, great. Yeah,
Vinay,
yes,
question
Lazaro.
from Ecuador, Dr. Juan Cristobal Rivera. Do you have any experience with the hot axios, the hot spaxus, please?
Yeah, we don't have Spaxis in the US. I think the best person to answer is Anthony.
Okay.
Yes, yes, yes.
Anthony.
Hot Spaxis, yes, I have experience. So actually, recently they have the new version. So the first version, the puncturability is not as good. But the new version is approaching very similar to axios. So puncturability, I would do a direct puncture with hot spaxes of PFC, gallbladder, maybe even gastroenterostomy. For the stent, I think the luminal opposing power is still a bit lower for spaxes. Again, they are going to have a new version with a higher luminal opposing power. So right now, I think I will still stick to hot axios. But I think in very near future, it may be comparable to stents.
Okay. There is another question. Can we use a non-cautery? That means, I think, not a hot one. The cold LAMS stent. Anthony, you can answer that.
The question about using cold axios or cold spaxes?
Oh, okay. I think definitely a hot system is much better because it's a single step procedure. So if you use a cold device, you need to puncture, dilate with cystotome and then balloon. So you end up losing a lot of water from fluids from the small bowel and it becomes undistended. So I think definitely a hot system.
You know, we used the the first publication we had in GIE. It was the cold system. It really was very tough. I'll tell you, the procedure was very long, and you have to dilate the tract with the balloon, you know, 6 millimeter to get the axios down. And when you push the axios, because you have to dilate the tract and then you have to push cold, you lose vision of the small bowel. The small bowel is not there next to you. And when you deploy the first flange, you're praying that's in the small bowel. You know, it's not 100% accurate. So, I mean, I don't think anybody should be using the cold to be honest.
Okay. Mouen, one question for you is, what is the diameter of stent you use? So you already said you prefer a 15 millimeter. Please expand on it. Why you don't use the 20 millimeter stent?
No, I use the 20. You know, like this last example I showed you, the one, the last example, small bowel was really dilated and nice and next to the stomach. It's easy to use the 20. When things are not perfect, you know, like some patients, there's a lot of peristalsis, you know, it doesn't dilate as good. Some patients, you know, something happened, you couldn't find the loop right away, so it's not as dilated. But if it's perfect, I use the 20. You know, between the 20 and the 15, you have, I think, 75% increase in the surface area, so it's good. So I would advocate for that if you have a good small bowel loop. Having said that, it's a little bit more technically challenging. You know, the flange is very thick. So you need to have, the small bowel has to be dilated because there's a lot of stent there. It's very thick. You need to have adequate area, the stented area in the small bowel. And then because the flange is thick, then you have more flange to push out of the scope. You know, when you're using the intra-scope deployment technique, then you have more sheath in the scope. So even when you push the whole sheath out, sometimes some stent stays in, you have to maneuver your scope, etc. So there is some little bit more some difficulty or a little bit more technical challenge. I haven't had a case where I misdeployed it because of that or failed because of that, but it's just something to think about.
Takao, what's your opinion? 15 versus 20 millimeters?
So basically I think bigger is much better. Like surgical gastroenterostomy, of course, I experienced around that more than 15 cases, 5 millimeter axials. Then, fortunately, the one case still already 7 years passed, and still open. That's why. So it's okay. Even 15, but bigger is much better.
Bigger is better.
Mm.
Acha, there are two questions on problems, and I want both of you to answer them. One is what to do if you puncture the colon accidentally. So has it happened, and if it happens, what to do? Mouen?
Yeah. So I tell you, if you use the finder needle technique, that's never going to happen. If you puncture the colon by mistake and it's a gastrocolostomy, you're going to have to leave it there for 4 weeks until it matures. And once it matures, then you take the stent out and close it with sutures. And you can close it with sutures. But do not try to remove the stent right away. It's not the end of the world. And you want to instruct the patient just to take liquids, not to take solids. Make sure you give PPI so that you're not causing colonic ulceration from the acid. I would give, just keep them on liquids. But it's something you can save. It's of course very disappointing and not a good thing to have. That's why I think the finder needle is a must. It's been reported. I haven't had it, but it's been reported.
Yeah. So the other question,
maybe Anthony Teoh reported it. I don't know.
Anthony, did you report one?
Luckily not.
So Anthony, now you get to answer the next one. So what to do if the proximal flange migrates away from the stomach? I guess what is meant is, suppose it goes inside. I think that happens rarely, but suppose it happens.
Yeah, so it can happen. So in several situations, for example, it can happen if you did a direct puncture and then you burn into the small bowel, but you haven't inserted the delivery system deep enough. So when you open the flange, you actually open outside of the small bowel. So in that situation, you have a small hole in the small bowel, and then you have a misdeployed distal flange. Another situation is you have completely missed your target, but you were not, and then you open the distal flange. In both situations, I would pull out the entire system. So if you have just opened your distal flange, if you pull out the entire system, then you'll have a small hole in the stomach. Then you can change your gastroscope to close that hole. With the hole, if you have a hole in the small bowel, I think it's usually okay if you keep the patient nearby mouth for 1 or 2 days, I think, and give them antibiotics, perhaps, and also nasogastric tube for drainage. Usually after a few days of conservative management, I think the small hole should close by surrounding omentum or surrounding tissues. So if you have misdeployed the distal flange, it's quite something that's not desirable, but you have to keep your cool and try to pull out the entire system, keep the patient conservative management for a few days, and then perhaps later on you can do an alternate procedure like duodenal stent, or try, if you're brave enough, you can try again gastroenterostomy.
Vinay, so one very important thing, like Anthony is mentioning, you're going to have these complications. So it's important to know the different scenarios like Anthony detailed, and each one how to manage. I'll tell you a quick experience before I leave here, how I've managed these, and I'm happy to come back later, but they're calling me for a case. So the most common scenario is one flange in the peritoneum and one flange in the stomach. Okay, so this is the most common misdeployment scenario. This is an easy fix. You just have to pull it out, and I close the gastronomy site with an Ovesco clip. These gastronomy, stomach wall is thick, muscularis propria is thick. It tends to close very fast. So what I do actually before I remove the axius, I put a little clip close to that area so that when I go in and easily identify the puncture site, and I close it with a clip. And frequently the small bowel contrast is still there, so you can reattempt the GJ. So that's one scenario. The second scenario is if you misdeployed the one flange in the small bowel, the second flange in the peritoneum. That's not a good thing to have, and it's rare. We've had it with like gallbladders, and stuff like that. So what you can do is with EUS, you can see the axius very well, and you can access its lumen with a 19 gauge needle, put a wire and to the small bowel and bridge with a through the scope stent, like an esophageal through the scope stent. But you can see the axius very well. So basically you're targeting its lumen with EUS. And that video, we have a video on GIE in GIE describing that. This other scenario where you have a small bowel puncture hole, like, you have a enterotomy. Anthony mentioned, some of these patients recover, but, if you have a lot of small bowel fluid in the peritoneum, it gets infected. That's the main problem. And these patients can have loculated fluids, a lot of drains. It's an issue. So I've had one of those where I did actually peritoneoscopy, with the scope. You have EGD scope there. I found the small bowel hole. You can put the axius through that hole, open the flange in the small bowel, pull it to the stomach, and deploy the second flange. So if you're able to find the hole, it also can be a relatively easy fix. And I also refer to your audience to a GIE video describing that technique.
Thanks, Mouen. Thanks a lot. I know you are being called for duty. I hope you're taking good care of yourself and for your staff. All the best wishes. Great job. I hope US comes back faster to normal. I hope you'll come back and join us again whenever you find time. Thank you. Thank you very much.
I will.
Thank you.
Thank you all, and good to see you, and good to see everybody.
Okay. Okay. That was a fantastic first lecture, and there are lots of questions on the outcomes and which technique is better, which technique is not. I think those questions we will field when Anthony comes to give his talk. The first three talks are on technique, so may I request questions on techniques. So the next talk is from Professor Takao Itoi. He is going to tell us about the Epass technique, how we do it with the Epass technique. Takao.
Okay. Hello, everyone. I'm Takao Itoi in Tokyo. It is 9:15 p.m. here. First of all, I'd like to say thank you so much, Vinay, and the AEG group, Flora, for having me in this wonderful webinar. I'm very happy to share this time. Okay, so let's get started. Can you see?
Yes.
Okay. So, all the people in the world suffering from COVID-19 now, it was also, this is the Mouen's group, Mouen's University, Johns Hopkins data. And it was also tough, very tough period in Tokyo. Last couple of months, and now the situation is getting better. Nevertheless, we have to provide the endoscopic service for emergent patients, right? So next, I'd like to introduce an interesting protection devices shortly before talking my main topic. As you can see, we created a dedicated and a transparent plastic tube for prevention of COVID-19 infection. Disposable glove Here, disposable globe fit it to the endoscopic insertion port here. Very small portion. And the tip of finger of glove is cut here to enable the endoscope to advance. This is a picture from inside of the cube. To imitate the patient cough, when the endoscope is inserted, experimentally a small balloon containing of fluorescence dye is inflated with air. Placed in the mouth of the simulated patient here, like this, and ruptured with the needle devices that pass through the endoscope. Then, we examine the spread of fluorescence dye visualized by ultraviolet light with and without plastic cube. As a result, dye was found on the operator gown, the floor, and glove, face mask, and hat in case of no plastic cube case. In contrast, when we use a plastic cube, only the inner surface of the box at the endoscopic insertion port side was contaminated. I think like this kind of plastic cube is very useful for prevention of the infection. So I'd like to show a small movie. Small movie here. So this is emergent ERCP cases. So time is limited. It shows shortly. Like this, we are doing the emergent ERCP and interventional EUS. Okay, let's go back to my topics. Gastroenteric obstruction is often seen in the progress of pancreatic cancers and the gastroduodenal cancer. Usually it's end stage. Nowadays, there are several salvage treatments for GOO. And recently, the EUS-Guided Gastroenterostomy, EUS-Guided so-called anastomosis seems to be one of options. So in this lecture, I'd like to show our procedure. I mean, EUS-Guided double balloon occluded gastroenterostomy bypass, shortly Epass, which we have developed. Before introducing our Epass, it is necessary to explain the difficulty of the standard EUS-GE. There are two big obstacles in this procedure. One is creation of this anastomosis, the other is access to the jejunum. In terms of creation of anastomosis, the LAMS made it possible to easily create the anastomosis between two organs. As you know, the inventor of this stent, Professor Kembimura, has reported the initial animal study of EUS-GE using a LAMS. At that moment, it was deployed from the delivery system with non-cautery tip. However, nowadays, fortunately, the LAMS with cautery enhanced tip is more safe and reliable. LAMS is available now. So next, access to jejunum is the most important and the difficult point in this EUS-GE. Since theoretically, jejunum is naturally shrinking, the extension of jejunum as a puncture target by some techniques is mandatory. For example, injecting saline, inflate, balloon, or combination. As already the Mouen showed. So anyhow, nowadays, there are several techniques of access to jejunum. So namely the transluminal direct needle puncture to inject the saline water in the jejunum, or intraluminal injection by ENBD tube, endoscope, or our procedure, the double balloon, and or a target balloon technique. So I think there are two important factors for successful and easy access to the jejunum. One is a finding of closer access portion, access side to the jejunum from the stomach. The other is how to keep distension of the jejunum sufficiently. It is very important. Regarding ideal access point, to find the access point, you know, as you can see, the anatomy, surrounding area of the ligament of the thorax seems to be closer from the stomach. Actually, upper GI graphy, as you can see, shows the shortest distance between the stomach and the jejunum, around here, around there. So next, how to keep distension of the jejunum. It is also very important. So some expertise, like Mouen Khashan, may said it is very, very easy. Just inject a large amount of water or saline at once and use a Buscopan sometime. Then you can do EUS-guided procedure. But you know, the water easily flows inner side, even using a Buscopan. So resulting in non-distended jejunum. Moreover, if contrast medium is used, the peristalsis of a duodenum or jejunum occurs soon. In addition, a lot of patients have a contraindication of Buscopan due to the heart disease, etc. So in case of a non-distended jejunum, pushing the EUS-guided devices may make the jejunum shrinking like this, leading to missed punctures, missed deployment. In contrast, in case of a well-distended jejunum, puncture and advancement of needle or advancement of devices are very, very easier than the non-distended program. So I let you know the jejunum distended model study. So here is a non-distended model. In case of a non-distended model, including standard amount of water in the glove. So you can see pushing the needle made glove scratched like this. And the glove is underwater also. Pushing the needle made glove more scratch like this. You can see the same image of EUS imaging of a non-distended model. The needle couldn't penetrate the glove, just squashed, just scratched. No penetration. In contrast, in case of a distended model, including the water sufficiently, a lot of water like a bowl, surface of glove had a very tension. So EUS imaging shows the needle could easily penetrate the glove and advance into the deeper portion of the glove, like a ball. So another important factor is puncture axis, direction of the jejunum. Longitudinal imaging is much better and easier to puncture. However, it is not always easy to get long axis like this. Sometimes we have to puncture at short axis at that time, keeping the jejunum distended. jejunum distended like a ball is very important for safe procedure, safe puncture, safe deployment. So that's why I created a dedicated double balloon tube which can inject only between two balloons, to distend the targeted jejunum, which is closer from the stomach. So I'd like to show the animation of the Epass. So firstly, endoscope is over tube is advanced to the structure and using a guide wire and catheter. Guide wire is advanced to the jejunum beyond the ligament of Treitz as far as possible. And then once the standard EGD is removed, leaving the guide wire and over tube in place. And over the guide wire, double balloon tube is insertion. Beyond the ligament of Treitz. And the double balloon is simultaneously inflated. Maybe between the two balloons, the distance of the length of the two balloons is 20 cm. And the inflation. And the over tube is removed, leaving the inflated double balloon in place. And the EUS scope is advanced in the stomach. And at this moment, we inject the saline with indigo carmine. You can see very nicely distended jejunum, and to detect easily by EUS imaging. And then finally, the hot actions is advanced in the distended jejunum. If necessary, we inject more and more additional saline. And like Mouen showed, same way, Epass is completed. Actually, so next I'd like to show the actual Epass procedure. This is a long axis puncture version. Same as this is a duodenal cancer, advanced duodenal cancer, and the guide wire advanced as long as possible beyond the thoracic ligament. And the standard EGD is removed, leaving the over tube and the guide wire in place. And over the guide wire, double balloon tube is advanced beyond the ligament of Treitz and the two balloon set. First balloon you can see here, and the second balloon here. And usually the balloon injection size Valladolid shape, and mostly the 40 to 50 cc both balloon. And so not yet inject the saline between two balloons. And once over tube, remove, leaving the double balloon tube in place. And the EUS scope insertion. And at this moment, we inject saline with contrast. And you know, the distended jejunum is a very correct target to puncture for Epass. Otherwise, other jejunum or small intestine or colon is shrinking, so we cannot see except distended jejunum. And if you can see very nicely distended jejunum with like this, very distended jejunum and longitudinal imaging. Long axis imaging is much better, much safer. And already so Mouen shows 2 cases. Very easy, like global drainage or shoot cyst drainage or wound drainage. It's complete. So next, I'd like to show the next movie. This is the outlook of the actual Epass procedure during the end of 2017 at the AEG in Hyderabad, you know, with Don Juan Seal and my junior. So I did the Epass by myself, almost all by myself. Firstly, now already the standard EGD was removed, leaving the guidewire in place, and by myself, we advanced the double tube over the guidewire and set the correct portion and inflate the 2 balloons simultaneously. At this moment, basically 2 people is necessary. And after inflated balloon, the echoendoscope is advanced in the stomach. Then they inject the saline with contrast to distend the jejunum sufficiently. And the hot action set. And after detection of the distended jejunum, I said again, it is a very correct target, like this, longitudinal. Maybe everyone can do if like this distended jejunum. And deploy the distal branch in the jejunum. And usually, recently we use a technique of the intra-channel, scope channel deployment technique. And finish. I remember very nicely. Oh, Sandeep here. Okay, so I'd like to show the next movie, short axis puncture. Sometimes, so no choice of a short axis puncture. At this moment, this is a very useful technique by Epass. Same as previous 2 cases, my cases, the EGD advance in front of the structure and the guide wire advance as far as possible. And the over the guide wire double balloon advanced beyond the ligament threads for correct position. First, yeah, here and here, between 2 balloons, 20 cm. And then, so injection to distend the jejunum. At this moment, looks half and half, short and long axis. But so 30 seconds looks nice, but finally is no choice this position. This is the short axis. You can understand the fluoroscopic imaging right there, like this. Short scope. Firstly, so ideally like this or like this is much better, the long axis. But in this moment, moving here and no choice, finally we decided this direct direction. And at this moment, this Epass can make it possible to place safely this kind of large stent. This is also 20 cm, and interworking channel deployment technique. And finish. You can see very nicely through the, yeah. And as Mouen mentioned, I also, I don't intentionally so dilate this using a balloon, the stent, immediately after deployment to avoid the risk of the bleeding or something. Anyway, so CAT scan shows very nicely opening the stent, and the gastrography shows gravitatically also very nicely the flows of the liquid flows go to the inner side shortcut. Also, the one autopsy shows very nicely creation of the anastomosis, like surgical gastroenterostomy. One previous technical review showed the Epass took the shortest procedure time. So at this moment, 25 minutes, but now it takes only 15 minutes for the beginning. So today you can see several presentations. Maybe you will be able to see several presentations of EUS-GE. I believe Epass is established a safe and reliable technique for us, taking shorter procedure time. Moreover, even in case of a long procedure, at that time, it is safely performed because double balloon can keep the jejunum distended sufficiently by additional injection without Buscopan if necessary. So, you know, all of us are not professional interventional endoscopists, right? Like Michael Jordan. But maybe just non-expertise or even beginners. Therefore, I'd like to recommend Epass. Also, the use of double balloon is still limited in each country in the world. So finally, I'm sure this must be a stressful time for you as you deal with the situation in your hospital and with your patient. Please stay safe and healthy, and I'm looking forward to actually seeing you again when the crisis is over. Thank you for your kind attention.
Thank you, Takao. That was a wonderful.
Nice presentation, Takao. Nice to see you again of Colombia. A question. In Latin America, we don't have the double ball of Takao. What is your technical advice to carry out the procedure?
And the other one is the one by Takao. I want questions on the technical aspects right now. One question, Takao, is cautery settings. Is it the usual cautery setting for ERCPs and other procedures or something different?
Great question. The standard ESD is auto cut, the endo cut mode, but this is auto cut mode, 100 watt. And so if we can use the ICC, the grade is 4 and the 100 auto cut mode.
Okay. And how much fluid do you inject between the two balloons? What is the amount usually?
Okay, so first, so many years ago, we used 15 cm length balloon between the two balloons. At that time, 100 cc. Now is we can use 20 cm length balloon, double balloon. At that time, 120 cc to 150 cc.
Okay. And Okay, what are the methods used for keeping the fluid in small bowel? So balloon is there. And you usually use 20 millimeters, Takao, or you also sometimes use 15 millimeters balloon? Sorry, stent.
Stent. So recently, almost all the 20 cm. If possible, I'd like to use more 20, 25 if possible, but I'm not sure that it makes sense. So, but
Okay.
yeah, bigger is much better, like surgical gastroenterostomy.
Okay.
Vinay, please, a
Yeah,
question for Takao, yeah?
yeah.
The question again, Takao. In Latin America, we do not have the double ball of Takao. What is your technical advice to carry out the procedure? If you don't have the double balloon or double ball of Takao, what is your technical advice to carry out the procedure?
So at that time, so of course, no choice. Just the injection method like Mouen Khashan, and if possible, I'd like to the catheter insertion instead of the double balloon, and inject a lot of water like a pump or something, but I'm not sure. Actually, easily the water or saline flows to the inner side. That's why. So, except expertise of interventional ES endoscopist, and this procedure is sometimes dangerous. Please wait the double balloon.
Thank you.
When is it coming? When is the Epass tube?
But now, except myself, in some countries, guys already, Anthony or Brazil or other countries, the guys already is now going to use.
Okay, good.
So can you comment something from Anthony?
Anthony, yeah.
So with the double balloon, it's a very good device because it's a very stable platform. You just need I think the most important part is to spend enough time to find the suitable loop or small bowel to puncture. So with this device, you don't need to be hurrying to change the scope and worry about the fluid escaping the small bowel. And I also agree on Takao's comment that because you are comparing to duodenal stent, and for duodenal stent, it's a very easy procedure. Most trainees can do. So you're trying to substitute a much more complicated or possibly more expensive procedure to duodenal stent. So you need to make it a lot more easy. So with Takao's device, actually my trainees are doing it. And when I supervise them, I don't need to sweat as well, because if I supervise someone doing GJ without the device, I'll be sweating a lot. So definitely learn it helps for beginners.
Okay. There is a question from Damien from Singapore. Hi, Damien. Any role for safety wire placement after hot axios? So is it a good, especially in the beginning, to place a wire and check that you are in the place?
It is a good thing. So sometimes in case of cholecystectomy, I use this technique. The guide wire mounted, but so no use guide wire before puncture. But after the cautery, the insertion of the jejunum, freehand, after that the guide wire impresses is one of option to avoid the unnecessary complication. But basically, after mature of these techniques, I just think take a lot of time or no good now. Like Manolo? How do you think?
Yes.
Freehand is
Manolo,
much
hi
better.
Manolo, welcome to the team.
Hello, can you hear me? There's a lot of echo
Yes.
and
Yeah.
background noise here. So I remember some DDWs ago that we were arguing at a symposium that Anthony put together on gallbladder drainage with Todd Baron, Takao. How come these days we need a guide wire to do ERCP and everybody says you cannot do ERCP through the papilla without a guide wire, and we can go transmural with no guide wire with hot axial. So this was the debate, and I remember very distinctly that maybe 4 or 5 years ago that I was against the guide wire for hot axials. Now I've become, at that time I was too conservative with the axials. I've grown used to the cold axials, which of course we needed to have a guide wire with the cold axials. But now I've changed and I've seen the beauty and the evidence of what Takao is saying, that the guide wire actually gets in the way when you're trying to access a mobile target, like the CVD or the small bowel. So, of course, it is, if you are not very familiar with the tactile feel that the catheter gives you, in other words, if you can sense, is there too much friction when my Axios catheter is going through through the elevator of my echo endoscope? Is there something funny? Is my position stable? You need to practice and grow confident. And for that, you need the pancreatic collections that are a very solid and stable target. For that early cases, for your learning curve in LAMS, you may use a guide wire. But once you're over that stage in your experience, I think that the freehand access is easier. And of course, as Takao mentioned, you may have already the guide wire inside your catheter just for safety, but not before you puncture your catheter into your target. Just inside the delivery catheter, as soon as you sense that you're entering your target, the small bowel or the CVD, that's the moment to push very gently the guide wire in, if necessary. So
Okay.
I changed from always use a guide wire mentality with Axios to freehand always if you can, if you are confident with the catheter, because it's easier. And if it's easier, probably it's also safer.
Okay, thanks, Takao. There are a lot more questions for you, but I think we are running a little late. So maybe we will take the questions after the next lectures. Professor Miranda is with us from Valladolid, Spain. Later, he's going to show us a live case also. Today, first he'll show us the technique of how he does EUS-GE gastroenterostomy.
So I'm very honored to be here. So I thank Dr. Vinay Dhir, the Asian EUS group, Ideal, and the Prince of Wales Hospital. So can you see my screen? Yes.
Yes,
so I guess,
yes.
So I'm gonna, Dr. Dhir asked me to show a lot of videos, but even if it's a lot of videos in this presentation, I want to give you some points. First, I'm going to mention the freehand technique. What makes this technique unique regarding other alternatives? A step-by-step description of the freehand technique for gastroenterostomosis, how to deal with problems, and then my conclusions. So the gastroenterostomy was first performed in animal models using the old axes that require needle, guidewire, dilation, stent delivery, catheter insertion. So the first case in humans were done by Dr. Itoi in Tokyo. It was pancreatic collection and gallbladder, and then he developed the gastroenterostomy technique. But these pioneers, Dr. B. Muller, in the animals, they had to use very special devices, very special catheter. That catheter that is no longer available is called the Navix. It used to have a side blade. There were also anchor guides to prevent the rebound from the pushing aside that Dr. Itoi has nicely shown to us today with the glove in the past, the glove model. So this development of the hot axis was very spectacular. A lot of thinking, a lot of design and engineering, a lot of experiments are behind this idea. This replaces all these anchor guide wires, the Navix catheter, everything, because this cautery tip at the right settings can like melt away tissues and very easily access one target from the next. This is, to my knowledge, the first reported case of the freehand technique. This is reported from Tokyo Medical University. This is afferent loop syndrome. And look how I'm going to play it again. You need to look how the tip of the catheter enters the small bowel, and then the fluid boils. The white bubbles, this is very important to see. And then you know for sure that your tip is inside the target, and then you can deploy backwards the first flange or distal flange towards your access site, which in this case is the stomach. This is the first reported use of the freehand technique with a hot axios. Then this is a European multi-center study on gallbladder drainage. And look at the procedural outcomes. In this study, operators of different levels of expertise, the median stent deployment time was here 4.5 minutes. And bear in mind that this is always hot axios, but when people were using the hot axios over a guide wire, in other words, needle first, then guide wire, then hot axios, the median stent deployment time was 7.7 minutes. And where they were using the freehand technique into the gallbladder, the median time is 3.1 minutes. And you may wonder, so is that a big difference? 4.6 minutes between the freehand technique and the over-the-wire technique? Believe me, when you are targeting the small bowel, 4 minutes, 4.6 minutes is really an eternity. A lot of things can go wrong in 4 minutes when you have a needle in the jejunum that you're targeting from the stomach. So this is a very important point for the freehand technique. Oh, the other thing, this is gallbladders, I remind you, you can use without fluoroscopy. So people, operators and oceanographers were confident that with the freehand technique, they didn't need any fluoroscopy or limited fluoroscopy at all. And this is not possible with the standard needle guidewire over the guidewire catheter insertion. So for the gallbladder, it has a lot of implications. You can go to the ICU and drain a gallbladder at the bedside without having to move a very sick patient. And it's also interesting for the gastroenterostomy procedure. So we have this freehand access technique for gastroenteral anastomosis. What do we need to bear in mind? We need to identify the target accurately. For that, we have the double balloon. This is one of the targeting devices that you can use when you're using the freehand access technique, but you cannot go wrong. If you're doing freehand access, you have to be sure that this is the small bowel. And the double balloon is one of the ways you have to locate your target. This is our series coming out, published in a much lesser journal, but the same year, that the Dr. Itoi's series came out in gut. This is patients coming from San Francisco, Dr. B. Muller, Dr. Barté, from New York, and also from Valladolid, 26 patients. And you see that we had the so-called assisted methods. The contrast field balloon was very commonly used, especially by the Americans in Cornell. We also use an ultra-slim upper endoscope parallel to the EUS scope, past the stricture nasobiliary drain technique, which is the one we're going to discuss today for freehand access location. So Dr. Khashab mentioned already this technique. You pass a balloon catheter, pass the stricture into the triangle, distal to the stricture, you inflate with balloon, and then you can grab the wire or puncture the balloon. So what is the step-by-step freehand technique that we use with a nasobiliary, which is wrong name because we don't reroute the catheter through the nose. So it's an orojejunal catheter, and the catheter is not in the bile duct, but it is the same nasobiliary drainage catheter that we use for the bile duct. It's nothing special, so this is readily available. I know this is a very sophisticated audience. Of course, you have to have the right indication. You have to have expert sedation and fluoroscopy, everything. But this is a very important technique step that I didn't want to omit mentioning. So I want to mention that it's very useful to have nasogastric suction or aspiration at least overnight for 12 hours before the procedure, because the risk is going to be much lesser. This is not a real patient, so I don't need to consent the patient to use the picture. So what do we need for equipment? Of course, linear EUS, therapeutic channel. Maybe you want to also have a forward or side viewing therapeutic channel endoscope. These days, we are using the echo endoscope for guide wire placement. We don't need another endoscope. And then, of course, we need cautery settings. Devices we use for a standard 0.035 inch guide wire. And we like very much this 3-layer catheter to advance distally the guide wire into the jejunum. The Oasis 8.5 French catheter. It is only 8.5 in the pushing segment of the catheter, but the tip is very floppy, is 5 French. Then we prefer 8.5 French nasobiliary drainage tube as opposed to smaller diameters, 7 French, because the flow that we get is much higher. Then we have a water pump, a standard endoscopy water pump to provide nice distension of the small bowel. We also like to mix some methylene blue and contrast in syringes. And then, of course, we need a cautery tip lamp that I will emphasize you need to deploy step by step. There are other cautery tip lamps other than Axios these days available, but I would say that the step-by-step deployment of the flanges is also very important. So we have everything ready before we start, and then these are the 3-step guide wire passage, scope exchange, target distension, catheter access, and then stent deployment. And I'm going to show you this in a video in one sequence that my colleague Ramon Sanchez Ocaña nicely edited for us. This is a case we did last Tuesday. This is the Oasis catheter. Look, it is very flexible, and we can make the catheter loop. This is the triangle, bulb, second, third triad, and the catheter, I'm going to show it again because I wasn't pointing to you. So to make the catheter go forward instead of looping, we bend the catheter, we push at the same time, guide wire and catheter, and we go distally. This is very easy to pass distally into the jejunum, as Dr. Itoi told us. Then this is the 8.5 catheter that over the wire we can push past the triangle, and we are using the echo endoscope. As we remove, You see, this is the echo endoscope. We don't need to exchange, and we go side by side with the same echo endoscope. We apply a little bit of traction on the nasability drain. Even we can reposition this loop in the stomach. We can pull backwards. And now we put some contrast with methylene blue. We have the echo endoscope in the posterior wall of the stomach. We get the alignment, but before I show you the alignment, this is 3 centimeters. So we can go freehand. We see the water boil. We deploy distal flange. We pull backwards. And these days we do intra-channel stent deployment. And then when we see the methylene blue coming, we know we are right. We didn't enter the peritoneum. We can also confirm by endoscopic vision. As I said, this is very fast, and this can be done provided we get the distension. So the critical issues with this technique is, one, you need to have a nasability drain in place, guideway passage. In this case, the nasogastric suction was not done. Stricture passage was very easy because we had a duodenal stent that was not functioning. So instead of the Oasis catheter, we could use sphincterotomy because we were already there. And then in this case, this is an old case that's already shown. We use a 7 French nasability drain. We are past the trides into the 4th duodenum. We inject contrast and methylene blue. And the second critical step, we have nicely distended small bowel, is pushing away the small bowel. Like Dr. Itoi was showing to us in his glove model. So we have good alignment here. We have the nasability drain. We were not using a pump in those days. We were using injection with a syringe. And you see, we think we have more or less good alignment, but this is not over distended. We are going through the stomach and not entering the small bowel. These we need to see with the ultrasound. We are creating tenting, pushing away the small bowel, and it is very important that we prevent that caveat. And we actually see the water boil. So before we deploy the distal flange. Otherwise, we're going to end up in the peritoneum. Again, confirmation. So this is the last part of our technique. You see here, we're not looking for the black marker. We are deploying inside the channel. And then the 5th step of stent delivery is that we down the elevator, we make the elevator down, we push with the catheter, and we push away the proximal flange from the channel. What problems can we have? First problem, the guideway does not go beyond the stricture. That happens very uncommonly, but it is typical of 3rd duodenal strictures. Strictures that are in the 3rd portion of the duodenum, sometimes it's really difficult. So what do? We do the graded injection technique to provide adequate distension of our target. So you see a collapse jejunal loop here. We can see the contour, the outline. So first we use a 22 gauge needle with saline. Of course, we can feel we are inside, but we cannot really feel whether we are inside the lumen or one of the layers. This is one bleb intramural injection. We're only injecting saline here, saline solution. Once we have an adequately distended, we create another puncture with a 19 gauge needle, and we put contrast and methylene blue. But first we need to distend with a 22 gauge needle. Now this is ready for freehand technique Axios with a hot Axios catheter. So we remove the needle and quickly, without giving any time for this fluid to go away, we push. And then we can do burn through the stomach and the jejunal wall. So what to do if you didn't see the fluid in the jejunum boil, if you don't see the white bubbles, do you deploy the stent or you don't? My recommendation is if you didn't see the bubbles boil, you have to be very careful. And if you don't see the catheter inside the small bowel, don't deploy. Go back and make another pass, because a puncture through the gastric wall is not dangerous, it's not risky, but deploying into the peritoneum is. So in this case, we didn't follow that tip, that advice. We deployed even if we didn't see the catheter boil. We ended up with misplacement. So this is not opening, this is in no man's land in the peritoneum. Of course, when we open, we don't see any methylene blue coming back. This is a sure sign that we're not in. This is peritoneum, for those of you who are not familiar with it. So what do we do when this mistake happens or this problem happens? This is called misplacement or misdeployment. It can be distally into the target. That never happens with gastroenterostomy. That may happen in the gallbladder. That also very rare, complete misdeployment or misplacement. However, this partial type of misdeployment is very common with the small bowel. All of you have seen it happening, especially the odds ratio is 10 times higher if the case is done at a live demonstration like the one we're going to do later later today in our unit. I hope we don't have that risk. However, it may happen and you need to know what to do. My recommendation is don't panic, don't rush calling the sergeant on duty. Try see if you can fix it. So if there is no solid content in the stomach, you are safe. Nothing wrong's happened. You first dilate the axius, leave a guidewire through into the peritoneum, and then very carefully, you remove over the wire the misdeployed axius. That's what I call the wise salvage technique. Balloon dilate your axius, leave a wire, and then remove the axius over the wire with fluoro control. And this is provided two things. Your stomach does not have solid contents because you did the nasogastric suction step before the procedure. And the other condition, very important, is that you have CO2 insufflation and very good control of the peritoneal pressure. And you don't need any special devices. It's just palpation of the belly, but one smart fellow or one smart nurse. And then the second thing you do is you follow the wire. You have the the scope clipping device, and then you identify the perforation. You may do suction or you may use a T forceps. You put both edges of the perforation into the cap and then deploy the ovesco. Then you are safe. You can put a duodenal stent and the patient will do well. The other not so wise salvage technique that you may employ, and that it's relatively easy to do if you have a double channel endoscope, is node salvage of the gastroenterostomy. This is balloon dilation of a 15mm axius. You have this jejunal loop filled with contrast right across your axius, and you can check with fluoroscopy. You can do needle knife of the serosa, and you can see the methylene blue and the contrast. And then, because this is only one channel scope, there is some pushing away of the small bowel, but you have a long length of wire. You can advance a second axius inside, over the wire, inside the small bowel, deploy the distal flange of the second axius, and pull backwards with a gastroscope, a therapeutic channel gastroscope, towards the first axius that is lying in the stomach, and then do the lambs in lambs technique to salvage the gastroenterostomy. So this is not the wise salvage, but it is a little bit wild, but it's also very safe if you have CO2 insufflation and you have good floral control. So my summary and conclusions, I would agree that with Dr. Itoi that the double balloon is a very good way to distend, target, and locate your jejunum for gastroenterostomy. But with an 8.5 French nasal-biliary drainage catheter past the Treitz ligament and pump insufflation, pump distension of fluid, and then contrast and saline, nearly the same quality of targeting and distension can be achieved with a device that is readily available at most units, and is also, I would say, the step number one, the advancement of the catheter past the duodenal stricture into the target is, I would say, it's easier, does not require any learning curve as compared to the double balloon tube. And I think that's all, because now if technology help us, we will be able to show one of these cases live, so we can discuss over the procedure nuances on the go later on. So thank you very much for your attention.
Thank you, Manolo. Thank you very much for a fantastic lecture. You really covered not only the good parts, but the bad parts of the technique also very, very well. And we have accumulated close to 70 questions now. Very, very interested audience. They want to know lots of things. So a very common question, Takao, is why is the Epass tube not available everywhere? Lots of people are asking. So is there a possibility of it being commercialized and being available easily to everyone, or it is still in the process? Takao?
I think so. Recent regulation is very getting strict and strict, very strict. So that's why it depends on each country. But recently, the most countries very high level of the regulation. That's why so non-approval devices cannot be easily used.
Okay. Okay.
Yeah.
Sorry
yes,
to interrupt.
Yeah, go ahead.
We are conducting a trial in Spain, a prospective randomized trials by Dr. Gornals in Barcelona. We are comparing axios with double pigtails for necrosis, or walled off necrosis. And we learned from the regulatory agency in Spain that the pigtails catheters are not approved for walled off necrosis. So can you imagine? This is the craziness of the regulatory issues. We were trying a new device, the hot axios, which is already approved by the European FDA, but the pigtails, nobody sought to look for approval. So this is crazy. And I've seen reports, Takao, of homemade double balloon, one in Canada, in Montreal. They are using interventional radiology balloons to create a homemade double balloon catheter for gastroenterostomy. But this is a real shame, but it's a real issue. And of course, with the nasal.
Manolo, the next question is to you. Thomas Verghese from Kerala, he's a surgeon, I know him very well. So a surgical question, how will you make sure that there are no blocks beyond in the bowel selected? So that is one question. Other question is, can the procedure be repeated if the stent gets blocked?
How do you make sure there are no small bowel, like in peritoneal carcinomatosis?
Right.
You not have only one point. I would say for our population, which is the same population that would undergo duodenal stenting, fortunately, that's a very small percent of patients. It's a minority. It's a very uncommon problem. But of course, in the right clinical scenario, you may suspect maybe pre-interventional imaging may help you, whether there is dilation that you can assess with CT or EMR enterography. Of course, during the procedure, you try to get an enterogram sometimes when that is suspected. And if you see a small bowel nicely, you assume there is no distal blockage. And of course, if there is distal blockage, you can also treat with another axios through the first one. And that there are reports coming from the United States and from Spain by Dr. Subtil in Pamplona, that you can treat distal jejunal obstruction by metastatic implants by EUS-guided enteral anastomosis from the small bowel to the colon, or from small bowel to other part of small bowel. So this is not, as opposed to surgical gastroenterostomy, a distal block is not a major issue because you can retreat the patient. How easy it is to intervene on a patient with a stent blockage? We have seen gastroenterostomy stent blockage very, very rarely, as opposed to duodenal stents, which are 9 or 12 centimeters long. The axios is only 1 centimeter long, plus the flanges. So it is very uncommon to obtain blockage, to end up with blockage. That has only happened to us in patients where we use for benign, and they live many months, years, like in chronic pancreatitis with portal hypertension. And we can treat very easily just by removing the debris and placing maybe another stent inside if that is relapsing problem. So I hope I've answered the questions, Vinay.
Okay, now another question for you, Manolo. Do you need to remove the stent ever?
Experience from Dr. Barthet in France and others, our own unpublished experience is that if you remove, the fistula shuts down. So if, at least for gastroenteral anastomosis. And that's a problem when you want to use this for permanent and benign disease, because you always need a stent. This is not, surgeons are right when they say this is not a real anastomosis. This is a 10 French hole that we are expanding with a stent into 20 millimeters. So it is not a real large anastomosis. But on the other hand, that feature that the gastroenteric anastomosis shuts down if you pull out the stent is a good thing when you want to use it for access in Roux-en-Y gastric bypass, because you are sure that the fistula is going to shut down. So if you pull out the stent and you are through the stomach, the fistula is going to shut down. So you always need to have something in place. Maybe, hi Mouen, I see you now pop up in the screen. So maybe new strategies will pop up and are evolving with these. If we use magnets, for instance, around an axios stent, maybe you can really have large area of tissue necrosis and you could end up with permanent anastomosis. But so far, if you pull out the stent, the anastomosis shuts down. I don't know if any of the panel have other experience, because this is very, very experienced and are using this for a number of indications, benign and malignant. Okay, so
I have one question which I want all of you to answer. It's a good question. Usage of EUS-guided gastroenterostomy in benign conditions. Brief answers from all 4 of you, please. Starting
Mouen
with
was the first one
Manolo.
to publish on that. Mouen was the first one in the world to publish on that. He probably has the longest and largest experience.
Yeah. So so it's a tricky indication, and it's definitely last resort. You know, patients, good scenarios for this. I've had few patients with duodenal hematomas. You know, this is a rare entity, but it can happen. I've had 2 of them. And we know these duodenal hematomas cause complete gastric outlet obstruction, but they resolve on their own. You can put a duodenal stent, it's not removable. There's really not a good option for this. This is a great patient for a benign EUS-GE. And after that benign entity is resolved, then you just pull the GJ, it closes, and then you're done. So this is an easy scenario. Other patients are those with the duodenal obstruction from chronic pancreatitis. So a lot of these patients have portal venous thrombosis, a lot of varices. So surgical gastroenterostomy sometimes is not a great idea. The issue with doing a gastroenterostomy is if you leave that stent for a long time, and I always think of benign obstruction as a lower grade obstruction than a malignant obstruction. What keeps this stent open in malignant obstruction is a flow. As long as you have flow through the stent, the stents don't get tumor or benign tissue overgrowth. What we see with benign obstructions is because food and liquid go both ways, the stent is not functioning at a level as in patients with malignant obstruction. So we see a lot of benign tissue overgrowth. I've had patients, if the stent is there for like 2 years, you go in, you can't actually see the stent. It's all benign tissue overgrowth. So if I'm doing a GG for a benign indication, I like to do an endoscopy every 6 to 12 months to keep an eye on the stent, to make sure it's not getting embedded, to make sure we don't have significant tissue overgrowth that's going to impede further treatment.
Any other points? Anthony?
No, we're not doing GG for benign indication.
Takao?
I have one longest cases, and 7.5 years back. I press hot action. No.
Cold action.
Yeah, cold actions, and then after 3 years, the membrane broken, and the ingrowth happened, and now 2/3 the lumen, the occlusion, but still keep open, and the
Oh, nice.
EGD is easily go and back. Yeah, it is a very nice case.
Okay. Manolo, have you placed for benign indications?
Yes, not very common. Again, malignant is a primary indication, and leaving aside access for ERCP in long-limb patients such as Roux-en-Y, for outlet obstruction, I agree with Mouen. A similar indication to duodenal hematoma is necrotizing pancreatitis in patients with transient duodenal stenosis because of edema, necrosis. And this is, people are not very much aware of this indication because these patients are usually managed with enteral feeding, PEG jet or jejunostomy. But really, if the patient is stable, necrosis takes a few weeks to heal. The duodenal stricture is going to be in place for 2 months or a few weeks. So we are doing gastroenterostomy temporarily in patients with that type of stricture. And this is very good because everybody is happy. The patient can eat, the patient can go home, is not wearing any external drains. For chronic pancreatitis is with severe portal hypertension, non-surgical candidates, and portal biliopathy. In the end, there are, over the very long term, there are problems with ambulation, dysfunction, and it is not so great an indication. But for temporary gastroenterostomy for outlet obstruction, I think it's a great indication, even if the patients are very few.
Okay. Okay, let's move on. We are short of time. There are lots of questions. A lot of people want to ask a lot of questions from all of you. So let's hope we can answer all those questions. So next, I am going to present the Indian data. We have started doing GJ late in India because the Axios was not available. So a short, small amount of data, only 1 year. How do I do it? Share screen. Can you see my screen? Okay. So as I told you, and Takao and others have mentioned, we keep getting patients of malignant gastric outlet obstruction, and they are in agony because there is a physical problem, psychological, emotional problems. We currently have had till few years back options of an enteral stent and a surgical GJ. Surgical GJ is a great procedure going on for 70 years and a good option in those who are expected to live for very, very long, 5, 6, 7, 8, or maybe 20 years. Enteral stent was a good procedure for those in whom you expected them to live about 3, 4 months and 5 months and not beyond that. If they lived beyond that, which is happening very often now because of the chemotherapy and other agents available for cancer management, we would see that the patient would come back with problems. In the last few years, we have this advent of EUS-Guided Gastroenterostomy, thanks to all these stalwarts who are sitting in front of us. Of course, Kenneth Binmoller introduced it first. It's about 8 years now. You saw that the procedure is evolving. We have 3 grades, 4 grades sitting here, and I think there are 3 different techniques that are being used differently in Asia, differently in Europe, differently in US. So we are still looking for a technique which can be propagated everywhere. We need comparative studies. So we are still in early days. Now, freehand technique like how Manolo did or how Mouen did is a fantastic technique if it can be done easily. But what I feel is that this technique is really for big experts. So if you are a beginner, you will feel very scared to puncture through a stomach. We are, barring Anthony, we are all gastroenterologists and we get scared of puncturing through the bowel. So that is an issue. And so especially in India, a lot of people keep asking about Epass tube. And that also unfortunately is not available outside of select centers. So currently in India, we have a situation where Axios arrived pretty late, almost I think 1.5 years now. It is expensive, especially if you compare it to the cost of an enteral stent. Technical expertise, we have great experts in India. But the issues that I just now discussed, the issue of anchoring the duodenum or a jejunum, it doesn't appear very easy to the beginners, those who begin doing these procedures. There is a worry about it. And there is, of course, a fear of perforation because then the case goes to a surgeon and everybody is not Manolo who wear an Axios. You can go through the Axios and do things like what he did, the wonderful procedure. And also surgical GJ and enteral stenting are well established, very well established. Enteral stenting is commonly done by most interventional endoscopists. So EUS-GE, for it to establish, needs to show that it is really superior to the other procedures, especially in malignant gastric outlet obstruction. So we started getting these stents last year and we started the procedure in March 2019. We were fortunate to receive an Epass tube from Professor Itoi as part of a clinical project. We started studying them prospectively. Patients with unresectable malignant gastric outlet obstruction with performance status 2 or below were included. All patients who come to me are offered both enteral stent or EUS-GE, and we give them advantages and disadvantages of both. And I ask them to make a choice. And what has happened is we get a 50-50, which is very interesting. About half of them end up choosing enteral stent, and I think that is probably because of the costing. Enteral stent placement is cheaper compared to an Axios placement, but the other half do choose Axios placement. So the method has already been very, very well described by Takao, Mouen, and Manolo. We do gastric lavage, Epass tube placement. Takao already showed beautifully. Then balloon distension, fill between the two balloons. We have exclusively so far used only a 20 mm balloon. We haven't used a 15 mm so far. We are a little more careful in all our patients because we are beginning. So we do a checkscopy after 24 hours. We put in contrast and see that everything is fine, and then only allow the patient to take the solids. And then we do follow-up scopy at 2 and 4 months. We call them back. Over the past 1 year, we have had 18 patients in whom EUS-GE was done. 4 were done by our friends who came to me for the conferences, Manolo and Anthony. And at the same time, we had 16 enteral stents. So it's a very small experience, 1 year experience. But we have learned a lot in these 18 procedures. We had, as far as technical success is concerned, both were very, very good. As far as GJ goes, we had 1 perforation. I will show you later about this perforation. This patient, we could not find the opening because there was a lot of bleeding. I think there was a splenic artery tear. The stent went into the peritoneum and was very close to the splenic artery. So there was a lot of bleeding. The patient went for emergency surgery and recovered. Went home, was eating well. And with enteral stent, we had a funny problem. We are doing a trial with Anthony on two different types of enteral stent. So one covered stent, distal flange, inverted upon itself. So it was there was no way anything would go through that. So we had to remove it and replace. But by and large, technically, I feel both procedures were very, very nice, no problems. The technical problems that we had with EUS-GE was already mentioned. Distal flange did not open fully in 2 patients. I have discussed this with Takao also in person. Probably we started deploying too early. There was little space. We don't know. In one of the cases, what we did was we pulled out the stent and then successful. In the other patient, I already told you, he perforated. So there was, so these were the 2 patients, 20 mm stents. I show you this one patient where we had the problem. So see here. So this is a nicely, we have a saline here. There is a nice loop of jejunum, nice position. But see here, now looking back, after talking to Takao, I think we deployed it probably too close. Should have started deploying it little distally, more close to this jejunal wall. So as we start deploying, we noticed that the stent is not opening. We saw it both in on the EUS as well as on the X-ray. So as you see, the stent is just not opening. And we have pushed it and then withdrawing the thing, assembly. So we withdrew the whole thing. You see there is some small amount of fluid collection here. This time we punctured a little deep. Same time, immediately. And luckily this time it worked. We could see the stent opening, although it did open slowly. So whether this was a problem of less space or a 20 millimeter or both, ultimately this small collection, you can see the fluid here was there. And then we could deploy this stent well. You can see here the stent is opening, not ideal, but it is still opening. I would have liked it to open a bit more. And then we deployed it in the scope as everybody else has shown. So I am showing these problems for the beginners, that these are the problems that even the experts will face, we learn. And so this time it was okay. You can see that the stent is nicely in place. Methylene blue was a very, very welcome sign. So what we learned from this was push it deep, very, very important, push it as deep as possible. And if it is not opening freely, please take a breath before you deploy the stent, otherwise there will be a problem. So this patient did well, he's started eating well next day, and we discharged him. He's okay still now. Patient did not have any significant pain. So this was the chondre which we did of him. If you see on this chondre, see this is a extraposition of contrast. This is the jejunum. You see here, there is a mild extraposition of contrast here, but the patient was asymptomatic, did not have any major problem. What about functional results? So excellent functional results with GJ. All patients, when we discharged, were taking solids. With enteral stent, the results were not so great, even at the time of discharge. Almost 25% of them were not taking solids, and this could be because of various reasons. It may not have anything to do with the stent. It could be that there is some aperistalsis in the stomach and the tumor condition and other things. So enteral stent results at the beginning, at discharge, also were not so good. At 1 month, I told you with GJ we had that perforation. That patient died after a month, although he was eating well. So this patient, one death in EUS-GE. In enteral stent, there was one patient who died at 3 weeks. Again, the patient was eating when he died. And one stent, interestingly enough, got blocked in 2 weeks. It happens sometimes. So this was this patient. The stent got blocked, and you see here, the stent is not seen. There is no stent here. It is completely covered by tumor. So this was an uncovered stent. We did a chondre, and you see here, this is a narrowing still there. So there is an ingrowth on both sides. And we thought we'll balloon dilate it, and because the patient had already spent a lot of money, so we balloon dilated. During dilation, it all looked very nice. That okay, patient. But the moment the balloon would be removed, patient was not able to eat anything. We sent him home with a rice tube for 1 week, thinking that maybe the dilation will happen gradually, but nothing happened. So this was the situation again after 1 week. Pretty bad situation. Patient was not taking at all. So we offered him GJ. He agreed for the GJ, and then we did a GJ. After that, the next day patient was eating well. So this was a crossover from enteral stent to GJ within 1 month. At 4 months, GJ, fantastic results. Patients are very happy. Everybody is eating, there are no problems. And now 42% of patients are not eating solid. They are not happy with, they are eating. It is not that they are not eating, but they are not happy with what they are eating. So these are early things. Our median follow-up period is only about 7 months. But already I am getting convinced that we should probably offer GJ more to patients than enteral stents, because the functional results are extremely good in these patients. See, this is a follow-up endoscopy we did at 4 months. You can see this is a black stent, completely turned black, but nicely seen jejunum. Absolutely no problems. Patient is happy. Patient is eating well. No problems at all. So my conclusions are what we found is it's a small data, but EUS-GE provides an efficient medium-term palliation. And if we are looking for an option in malignant obstructive jaundice, where you need to palliate for about a year in most of the patients, it looks like a very, very good option compared to a surgical GJ also, because the patient doesn't want to go for surgery with an advanced cancer, and probably surgical GJ is good for benign indications, but for malignant indications, enteral stents, patients are not happy for the money they spend, quite a few of them. And that is the issue. While with enteral stent, most of the patients are pretty happy. I think what our data does is basically confirm what Manolo and Mouen has already published with their large comparative trials, that it is a better options compared to enteral stent. We will listen to Anthony, of course, as to what he has to say about comparison of various techniques. So I end my presentation here. Okay. We will take questions. Okay, lots of questions. Can we use a covered biliary stent instead of second axios in misplacement situation, as it is expensive to use two axios? This is from India. Manolo?
Not a biliary or just wall stent. I've heard
covered biliary.
No, definitely not biliary. It's too small, too short. But I know of cases, I don't know if Mouen's or Michel Cahale, where they've salvaged this misplacement by using a long enteral or esophageal stent. So, but a biliary stent, I think, is too thin and too short. So another way to do the stent in stent will be using a larger, high caliber enteral through the scope or esophageal stent. Mouen maybe has some experience in that.
Yeah, the NITI-S Taiwan through the scope esophageal stent. So that's probably your best option. And the shaft diameter of that, I think it's 18 millimeter. So if you're using a 15 millimeter axius stent, that will completely seal it around. So that's probably your go-to salvage stent in specific instances.
Okay. What should we do if inadvertently we puncture the opposite wall of the jejunum? Takao?
Sorry again?
What should we do if we puncture the opposite wall of the jejunum? No, you punctured too much.
I have no experience, but your first non-deployment, the opening case, I guess you should push more.
Right,
yeah,
right.
Yeah.
I took advice from you after I had this problem.
I think so, yeah.
Yes. Okay. What should be the... Yeah, Manolo.
I'd say if you have a well-distended small bowel, it's really difficult to burn the opposite wall. So the issue is actually the opposite. You cannot even burn through the first wall. So let alone burn to the opposite. But if you are so ardent that you burn, stomach, first duodenal wall or jejunal wall, and then second wall, I guess that if you properly place the axios, balloon dilate, and go in with the scope and clip, it will be okay. But that also, I have a lot of trouble, like I've shown in the videos, but I've never had that trouble of burning into the opposite wall.
So is there a minimum? Sorry, yeah.
Theoretical concern that you have that in your nightmares, but not in your real life.
So what should be the minimum distance between the stomach and jejunum before puncture? Anthony, is there a, like we have for walled off necrosis, is there a distance that you would say for puncturing?
Yeah, so the axial stent is around 1 centimeter in length. So in theory, if anything is more than 1 centimeter, then you try not to puncture that. Although you can occasionally try to stretch it by a few millimeters, but yeah, in general, 1 centimeter.
What is the benefit of EUS-GE over laparoscopic GE? Are you covering it, Anthony, in your talk? Then you answer it.
Yeah, I'll be talking about that.
Okay, let's leave it there. Okay, we discussed benign
You know,
GEO.
benign?
Yeah.
So we know that in some cases, a laparoscopic gastroenterostomy doesn't work well sometimes. You know, in case of surgical gastroenteral, sometimes the anastomosis bend. So bend, and that causes dysfunction of the flowing of the food or liquid. That's why. So theoretically, the always open by hot axis. That's why it's much better. I guess theoretically also much better than the laparoscopic GJ.
And also there is a risk of gastroparesis. Probably Anthony is going to talk about it. There's an incidence of gastroparesis after any kind of gastric surgery, including GJ.
One question to Takao. Any danger of the balloon catheter, the Epass catheter, getting stuck between the stent flange and jejunal wall? Nice question. So your Epass catheter getting stuck between the stent and the jejunal wall?
Of course, after the fully deflation of the balloon and remove, just no problem.
No, we never had such problem.
Yeah.
But theoretically, it appears that it may get stuck.
Exactly.
Yeah. So, is the overtube to be taken along with gastroscopy? Yes. That answer is yes. So, it is the first part is gastroscope with overtube, and then you pass the Epass tube through the overtube. Okay, I think we'll take some more questions afterwards. Anthony, you are on. Anthony is going to distill for us what is the current status and what should be the future as far as the various techniques are concerned. Anthony?
Okay, can you hear me?
Yes.
Okay, do you have my PowerPoint?
Yes.
Okay, so I'm going to be talking about EUS-GE versus stenting versus surgical GJ. So once again, thank you very much for letting me speak. Very happy that so many of you are interested in this new technique. These are my disclosures. So tonight we've been concentrating mostly on EUS-Guided Gastroenterostomy. But this is just one part of a whole family of EUS-Guided Gastroenterostomy procedures, like EUS-Guided Transgastric ERCP edge procedure, as well as the EUS-Guided drainage or atrial limb obstruction. But of course, this is I'm going to still be concentrating on the EUS-Guided Gastroenterostomy because this is the most common procedure amongst all these different types of gastroenterostomy. So when we are dealing with the malignant gastric obstruction, as you all know, we have several options. Firstly, of course, we know that we can deal with this with a duodenal stent. The other traditional way is performing a surgical gastroenterostomy. And recently, we are now able to do gastroenterostomy. So each technique has their pros and cons. For duodenal stent, it's a simple procedure. It's cheap. It can be under sedation, but a major drawback is the lower patency rate. The other option is a traditional option, is surgical gastroenterostomy. In principle, because the GJ is situated away from the tumor, so it is believed to have a longer patency. Problem with surgical GJ is that it needs to be done under general anesthesia. It's a bit more expensive than the duodenal stent. The procedural time, I'm going to show you a video later on, is much more longer than a EUS-GE. And because there are some surgical scars, in theory, there might be a longer recovery time. For EUS gastroenterostomy, of course, the stent is placed away from the tumor. So in theory, the patency should be longer than the duodenal stent. We are doing this now under IV sedation, but the major problem is we need a level of expertise. Also, there's always a risk of adverse events which you may need to intervene. Again, this will require a high level of expertise. And of course, axial stent is still quite expensive. So this adds to the cost of the procedure. So which one is the winner? We need to think about all these different issues when considering the optimal procedure for the patient. So laparoscopic gastroenterostomy. So this is after a distal gastrectomy. So this is a remnant stomach. First, we need to make a hole in the remnant stomach with a ultrasonic dissector. Afterwards, we need to find a piece of small bowel. Again, we make a hole right here. Because nowadays we are usually performing a stapled gastroenterostomy. Then we insert a stapler. One end of the jaw is in the small bowel. And then the other jaw is inserted into the remnant stomach. And then we close the staple. To perform the anastomosis. There's still an enterotomy right here. So we need to suture this bit, which adds to another 15-20 minutes to the whole procedure. So usually this will take around half an hour or 45 minutes. But I can tell you this is much more time consuming than the EUS procedure. So after the suturing, the completed anastomosis will look like something like this. So on another patient, this is a B2 reconstruction, Bureau of 2. So remnant stomach, small bowel, and anastomosis right here. So this looks like the picture that you see in the textbook, something like this. This one is not a human. This is a pig. And it's actually a gastroenterostomy performed by EUS. So this was when we started the procedure, before we started the procedure a few years ago, we did some experiments in pigs, and this is by 20mm axials. You can see the anastomosis is very clean. There's minimal adhesions between the two organs. And when you cut open the specimen, there's a very nice union between the two structures. So this is a EUS appearance of the EUS procedure. So you need to know that when we perform a EUS procedure, it's slightly different than from a surgical gastroenterostomy. Surgical gastroenterostomy is between the stomach and the proximal jejunum. But in the EUS procedure, very often we are actually doing a gastroduodenostomy, or because the stent is placed at the D3-4 level. So this is right at the angle of the DJ. And this is maybe more properly called a gastroduodenostomy. So it's slightly different than from the traditional gastroduodenostomy. Duodenal stents have been around for quite some time now, but there has also been some advancement. So this is gonna complicate the picture a little bit more. There are some new stents which are partially covered duodenal stents. So you can see part of these stents are uncovered and in the middle is covered. So it works just like any of our esophageal stents where the covered portion is at the tumor level. And then again, this covered portion can theoretically reduce the chance of tumor ingrowth. So another thing that I want to point to you before I tell you which procedure is better is as we do more and more these EUS-guided drainage procedures, gastroduodenostomy, I become more aware of the anatomy of the duodenum. So this is the typical picture of what you see in a textbook. So this is a usual C curve, followed by the DJ flexure right here. But as you do more and more of these procedures, actually you see that the anatomy is not always like this. There are actually many variations in the DJ flexure. So this is a normal position, which is a C curve. But there are also some partial malrotation like this, some non-rotation of the duodenum where the small bowel is located on the right side. There's also a corkscrew-shaped duodenum, some partial duodenal rotation, or a very redundant duodenum, which I've also seen. So you can see loops of duodenum going around before coming back to the DJ. So you need to be aware that there are quite a bit of variations of the DJ flexure because when you perform the EUS procedures, you need to be aware that sometimes the location of the duodenum that you are puncturing and how these variations may affect your decision in which part of the duodenum to puncture. So I'm going to give you two CT films of 2 patients. So I just want to illustrate that although the procedural aspects are very important, the patient characteristic is also very important, and it may affect your decision on which procedure to perform. So this is a patient with a metastatic renal cell carcinoma. You can see a distended stomach. But right here, there's a big metastasis. So right at the D3-4 DJ level. So this is going to be blocking your view of the small bowel. You can, for these patients, you can try to perform a EUS procedure, but you should also have a second bowel procedure. You should have a plan B. So in these patients, I would want you to think about which procedure may be more useful for the patient, more applicable for the patient. And maybe, for example, you should need to think about bowel procedures like stenting versus left GJ. In another patient, you can see a huge tumor over the right side of the abdomen. So again, with this sort of characteristics, it will affect your decision because if you put for example, you place a duodenal stent, very likely the stent won't open in such a big tumor, especially if it's going through a curve. So again, this sort of patients, you would decide against stenting and more inclined to perform a gastroenterostomy, whether by EUS or laparoscopic approach. How about this patient? So what is the abnormality in this patient? So this, you can see a distended stomach. So when I first saw the CT, I thought this was a bit weird because you see all the small bowel was on the right side of the patient. And if you do a axial cut, you can see all the small bowel is on the right side of the patient. So this is actually a patient with a malrotated small bowel. He was not having any symptoms from this malrotation, and it lived for years until he get this tumor. So again, with this sort of patient, would you perform a EUS gastroenterostomy or other types of procedures? So I think we all know that duodenal stent has been around for a long time. There has been many studies comparing duodenal stent versus surgical GJ. One meta-analysis, which was quite some time ago, almost 20 years, showed that had data on 1 RCT in 8 comparative studies. And they showed that the endoscopic stenting was associated with higher clinical success, shorter time to oral intake, less morbidity, and less incidence of delayed gastric emptying. But they didn't address the most important issue, which is the rate of intervention, readmission, and also patency. And after that, this meta-analysis also suggested perhaps GJ should be performed in surgically fit patients because the patency may be longer, or it can be performed as part of a staging laparoscopy procedure. And after this meta-analysis, there are several randomized trials, But unfortunately, all these trials, very small sample size, 9 patients, 12 patients, 20 patients. Technical clinical success rate were similar. And in terms of adverse events, some showed equal adverse events, some showed surgery to be worse, and other studies showing that the stenting group had more adverse events. So all these randomized trials failed to distinguish which is a better procedure. During my preparation for this talk, I also came across this very interesting study from our Japanese friends. Even with duodenal stents, the type of duodenal stent also affect the patency. So they compared the wall flex stent, which is known to have a high axial force, versus the NITIA stent, which is a low axial force duodenal stent. This is what was not a big study, randomized trial of 38 patients. They managed to show that with the wall flex, which had a high axial force, the rate of reobstruction is actually much higher. So even within duodenal stents, the type of stent would affect the patency rate. And this is one thing that you also need to consider when doing stenting. So this is the patency curve showing that with a low axial force stent, like the NITIAs, had a much better patency. This is, again, a more recent study but from our Japanese friends from Kitano Sensei. This is a randomized trial of a newer type of stent, which is a partially covered stent versus an uncovered stent for malignant gastric obstruction. So in theory, with a partially covered stent, again, it can prevent tumor ingrowth. So in theory, it may be associated with better patency rate. So this study was presented by Kitano Sensei in DDW oral presentation last year. And I know that with personal communication, he is submitting this paper to a big journal. But so these are the two types of stent. One is an uncovered duodenal stent. The other is a partially covered duodenal stent. It's a big study, 184 patients in the cover arm, 182 patients in the partially covered stent arm. Interestingly, so they show that the uncovered duodenal stent actually has a higher patency rate, as shown by this curve. There's a longer time to stent dysfunction in the uncovered stent arm. This is particularly true in patients with extrinsic tumor, where the uncovered stent has had a longer time to stent dysfunction. So with personal communication with Kitano, he mentioned that in patients with extrinsic tumor, actually the covered stent there's a higher rate of stent migration. So this is kind of expected because in patients with extrinsic tumor, there's no tumor actually inside the lumen to hold on to the stent. So the stent migration is significantly higher. So the difference in time to dysfunction is not different in patients with intrinsic tumor. So meaning that even with a partially covered stent, in patients with primary malignant gastric obstruction, perhaps the stent doesn't prevent tumor ingrowth. So their summary is that the time to stent dysfunction was longer in uncovered stent group in all patients, as well as those with extrinsic tumor. And we are also performing a similar study comparing these two types of stents in patients, particularly with intrinsic tumor. So going back to our patient with a malrotation. So you see all this small over here. So which procedure would you perform? So luckily, we have the double balloon device, Itoi Sensei's device. So even with a small bowel located in the right side of the abdomen, we thought we could have a try to see if we could perform a gastroenterostomy. Of course, with a atypical anatomy, the procedure is more difficult You need to spend more time in trying to find the location of the puncture. Our gastroenterostomy was located at the enteral because all the small bowel is in the right side. And we did spend some time to try to look for the best location. And in this patient, it was particularly useful because we had the double balloon device, and we could really sit back, relax, and use our time to find the most suitable puncture point. So passage of the double balloon device is just the same. This is the obstructive site. And on guide wire, we pass the double balloon device to the proximal jejunum. And afterwards, we distend both balloons, just like Itoi teaches us, the way Itoi teaches us. One balloon is here, the other balloon is here, and we distend this part of the jejunum. So these are the two balloons. And I was happy because I had all this small bowel in between as a potential target for puncturing. So my stomach is right here, and my puncture site is probably somewhere around here. So after the two balloons are distended, we injected solution in between the two balloons. You can see my scope position is a bit unusual. It's almost at the enteral, but I was able to find a piece of jejunum in a very nice position, longitudinal window. And after puncture, easy deployment, no sweat in deploying the stent. So in terms of outcomes of different studies, I think all of the giants are here except Christopher Thompson. Mouen Khashan first presented his results comparing EUS gastroenterostomy versus duodenal stent. The technical success is a bit lower in the US arm, probably because we are all at that time still in our learning curve. Clinical success is higher in the US arm, adverse events comparable. Reinterventions is significantly more in the duodenal stenting group. Manolo published this other study comparing US versus laparoscopic GJ. Again, the technical success is slightly lower. Again, I think it's because we were still at the learning curve. Clinical success is a bit lower, again, because maybe related to the technical success rate. Adverse events rate is significantly higher with the laparoscopic gastroenterostomy. With Christopher Thompson's group, again, comparing stenting versus gastroenterostomy, technical success, clinical success is 100% in both. Clinical success significantly higher with a gastroenterostomy. Adverse events rate lower with US, and reinterventions is again lower with reinterventions. So suggesting that the US gastroenterostomy may be associated with better clinical success, less adverse events, and also lower reintervention. So we are now performing this randomized trial. Because of COVID, we haven't started being able to properly recruit patients, but hopefully with the easing of the infection around the world, we can all join hands and perform this randomized trial together. Another thing that I want to just shortly mention about is in the past, we had a lot of discussion about concomitant biliary obstruction. We know that there are different types, type 1, type 2, type 3, and there were a lot of discussions on how to tackle this situation, whether to stent the duodenum first or stent the biliary ducts first, what is the technique of cannulation if there's a duodenal stent present. And with published studies, there are various rates of technical success being described. But with US procedure, nowadays we can perform both procedures at the same time. Again, Mouen published this small study in 7 patients in which all patients had a gastroenterostomy and BD done at the same time. And I think this is a very nice indication. So because with US, it really doesn't matter with whether we stent the duodenum first and we perform a gastroenterostomy first, or perform a biliary drainage. And with biliary drainage, we can also have choice between CDS versus XGS. So with US, it really opens up our option in these difficult patients. So in this patient, again, this was done by Itoi in our workshop many years ago. He first performed a gastroenterostomy in this patient, followed by a mark. This is the usual gastroenterostomy. And then afterwards, Mark Giovannini performed a hepatogastrostomy in the same session in this patient. So again, showing you, it's a very nice way to deal with the patient with a double obstruction. And with the US procedure, it really opens up a lot of possibilities in terms of treating these patients. So a EUS-guided double bypass is now a possibility. So in conclusion, the optimal technique of EUS-guided gastroenterostomy is still in evolution. There are some data suggesting a EUS-guided gastroenterostomy may be superior in terms of the many outcomes. But I think we still need a standardization of the technique because we want this procedure to be very safe, and we want it to be able to be done by even our least experienced colleagues. Because with duodenal stent, it's a very easy procedure, it's a very safe procedure, it's also cheaper. So we really want the US procedure to be equally similar in terms of these basic issues. So for EUS-GE to be popular, we need to overcome issues in cost and also expertise in the future. So thank you for your attention.
Thank you, Anthony. Wonderful summary of the current opinion and the literature, and also some very, very wonderful videos. We are running about 15 minutes late. So if Manolo is ready with the live case, otherwise we can take a few questions. Manolo, are you ready? Can you hear us?
Yes.
Okay, he has muted his mic. Manolo?
Yes,
Okay,
I'm
let's
ready.
take some
We are
questions.
ready.
You're ready?
Hello.
Yeah, hi. Let's start.
So, can you hear me?
Yes.
I have a microphone.
The volume is very low.
That's because of COVID.
Can you turn up the volume?
I have to shout, or maybe I'll have to put my mic inside the mask.
Oh.
Can you hear me better now?
Yes.
Maybe I should put the mic into my mouth. So,
okay, what's the case?
This a young lady with an uncinate neoplasm, unresectable, and she just had EUS FNA done by my partner Carlos de la Serna. And he's behind the eye shield. And, she's with gastric outlet obstruction. Despite having had an NG tube overnight, she still had a lot of fluid content. And unluckily for us and for herself, of course, the stricture is located in the third duodenum. If you remember what we discussed during the talk earlier, the third duodenum is the most difficult location for the guyeware to go through, even if it's one of the least common. It is precisely in uncinate neoplasms that cause third duodenal stricture. Now I'm going to start with a side view in scope. So
please give all of your staff a big thanks for staying late on our behalf. I know it's a Friday evening. Manolo?
So we are with the side view and scope. Can you, oh, okay, you have the floor, the room image. We're gonna switch to endo. So you see a lot of fluid, a lot of bile, retained content in the stomach despite the NG suction. Can you see the endoscopy now?
Yes.
Okay, so as I said, I'm with a duodenoscope through the pylorus. Okay, so this is at the apex. It's not so bad. It is not so bad. At the apex, I can go through, and then the real one, the real stricture is here, right distal to the papilla. Let's try our luck with an Oasis 8.5. And the beauty of this catheter is that the pushing segment of the catheter is 8 French, but it has a very soft tip and it has radio opaque markers. So let's see if we can make a jaguar go through. I have a very good tactile feedback. My catheter is going nicely. I think we got lucky this time. The catheter got through. Now we put some saline into the catheter. We're going zoom uno. We're going to zoom in with the fluoro un poquito vertical hacia mí. No. Ahora después. Maybe you can take a look at the fluoro. See how we manipulate the guide wire. Remember, the tip of my side viewing endoscope is in the distal second duodenum, facing the beginning of the third duodenum.
We need fluoro pictures, Manolo.
Okay, Ramon is working on that.
Okay.
This is everything, the IT is
Okay.
homemade.
I know. Great
And
effort. Thank you.
We are not Indians, so gastroenterologists in Spain do not have an IT
Great
background.
Great effort.
Do you get the fluoro now?
Yes, fantastic.
So
nice
you
view.
see Almudena in my right hand side is pushing the guide wire. Oblicuas un poquitín. And you see what's happening with the guide wire is taking loops, but not moving farther deep. So what I'm going to do now is push, empuja, at the same time that she pushes, try to loop this Oasis catheter. Empuja, fuerte. Okay, it's not happening. I'm pulling back. Retira la guía, retira, mira la escopia. Okay, and I'm trying to empuja, yeah. Okay, very easy. Now the guide wire is going forward, and you see I'm pushing the catheter. I'm past the trides now. I see some contrast. I don't know if this is from exam at the referring hospital. I don't know. I would like to ask now Takao and Anthony, is this deep enough for you? Puedes mover un poquito de lado hacia
Looks nice. Beyond the ligament of the trides already.
Yeah, looks like.
Okay. Can we exchange? Now we hacemos intercambio. We remove the catheter, el drenaje nasobiliar, preparado y purgado. And we're going to use, so I'm not using fluoro. I will for you. So I have a long distance of catheter. You see the papilla, the patient is not jaundiced as far as I know. So Dr. De La Serna, my partner Carlos De La Serna, confirms that the patient is not jaundiced. This is just a presentation with gastric outlet obstruction. And in case she has developed symptomatic biliary obstruction, you see ERCP is perfectly doable in this patient. That's the papilla, and the stricture is distal to the papilla. A case might be made for EUS-guided biliary drainage as patients with synchronous biliary and duodenal obstruction have a higher likelihood of biliary stent dysfunction if drainage is done transpapillary. Okay. So do you see the endoscopy now?
Yeah,
Yes,
perfect.
yes.
Show you
That's perfect.
endoscopy or fluoroscopy. Now this is endoscopy, just to give you a brief glimpse of the 8.5 nasobiliary drain catheter. You see this is 8.5. My assistant is putting some traction on the wire. I'm going to give you the fluoro view now.
Yes.
So the catheter is moving nicely. Tira de la guía, tira más, tira más, tira más, tira más, tira más, tira más, tira fuerte, tira más fuerte. Okay, I think that's okay. I'm going to remove the echo endoscope, the duodenoscope, leaving the guide wire. Quítanos un poquito de zoom. I'm going to leave the fluoro room, fluoro show. Venga, mueve un poquito vertical hacia ti. Alguien que recoja la cabecera. Sigue, sigue. So now we exchange the echo endoscope for the duodenoscope for the echo endoscope. Maybe you want, this is relatively easy, but maybe we can have a room view now. In fluoro, we are okay. This is what you see. We leave the guide wire in place until we remove the duodenoscope. Now, Ramón, mostramos el ambiente. So, we have to exchange scopes, and in the meantime, we will show you how we handle this. So now we remove the guide wire. We put the cap back on the nasobiliary drain. I use fluoro that you cannot see, and the nasobiliary drain stays in place. As I said, the real name for this would be orojejunal catheter, because this is not draining anything. And the time that we have here now spending in exchanging scopes, we could have saved if the stricture would have been in the first duodenum. Now, Almudena, my assistant, can we have some zoom here, Ramon? No zoom. So this is low cost transmission. Sorry. Basically, we're putting the cap back on the nasobiliary drain and then connecting to the pump. So we have a regular water pump, and we start putting I can start putting some water through the pump. Now, my assistant Almudena, she's holding the drain, the catheter, just to prevent looping into the stomach as I go alongside. I'm gonna put the end of view on the catheter. So I go alongside Ramon, la endoscopy. We go back to endoscopy. So our IT guy is also on endoscopy. He's running around the room very carefully.
We don't see the endoscopic image.
Yeah.
Okay, yeah.
Can you see the endoscopy? You see the drain in the esophagus, right?
Yes.
I'm going alongside. I'm using fluoro that I cannot show you. No, espera, tranquilo. So we have a little bit of looping here in the stomach. That was before I removed the air. I apply suction. So I'm doing some suction, before I'm moving towards the posterior gastric body wall. ¿Me podéis dar una mascarilla distinta? Y... ¿Esto por qué no se ve el eco? I'm going to switch the ultrasound on. So, but I'm going to step on the pedal, looking for the small bowel. Okay, give me. ¿Me das un poco de zoom, por favor? So, yeah, can you hear me better now?
No.
Much better, much better.
Okay, quita este otro. Ramón, fluoro now.
La tienes. There is an echo, lot of echo coming.
So you see a lot of echoes, bright echoes. This is the small bowel, right? And the idea is to remove that, remove that air and fill the small bowel with...
Show us endoscope image, echo endoscope image, US image.
This is too much. We cannot... What do you want, Takao? EUS?
No, yes. Now, so we can see only fluoroscopic imaging.
We cannot see both. I just wanted to show on the fluoro the repositioning of the drain. So I'm going to pull on the drain. You see on the fluoro?
Yes,
it's straightening.
I understand.
You see the pigtail coming a little bit closer. The pigtail is there next to the echo endoscope. Now, when I press on the pump, I can see the bowel. Okay. And now I can show the EUS. Pon el eco. Do you see the EUS now?
Yes.
Yes.
Okay. Hopefully, there's still some air. Where I did not want it to be. We haven't been putting a lot of air. Okay, I'm looking the wrong way. I'm using the fluoro to adjust my position. Que sí, que lo ven. Se ve aquí. I'm zooming in on the EUS. I don't know if you can see that.
Yes.
Apologize for the quality of the image.
It's nice, very nice.
Is it good? Okay.
Manolo,
Yes.
I guess a lot of water going back to the stomach, right?
That is true. That is true. Yeah, we have an issue with that. Let's see on endoscopy how it looks like. Let's put some air. We did have a lot of bile, if you remember. So the stomach does not have a lot of fluid inside, okay? Just this puddle here. So I'm going back to EUS. I'm having a little bit difficulty in finding the right loop of bowel. Okay, that's very nicely drainable, but it's not our target. So maybe it has something to do with what Anthony told about the variations in the anatomy. So maybe we could use a little bit contrast. Now
Yes.
there is some highlights. And again, as Takao said in his lecture, we wait patiently until we have a nice window. Vamos a poner, so we're gonna use a little bit of help from X-ray. We're putting contrast through the nasobiliary drain and some methylene blue. Contraste con azul. Sí, sí. Venga. So there is bowel there with air, but it is not nicely distended. ¿Qué pasa? ¿Que no va?
So Manolo, so what position are you having the patient, and have you given the patient any Buscopan, and how much have you
Patient
injected?
is left lateral semi-prone.
Left lateral
It's
semi-prone.
almost on his belly. That might be one of the difficulties why the fluid is not staying. She's too flat on her belly.
Okay.
So probably a little bit
Any
more
Buscopan?
sideways. Pues estamos inyectando contraste. Now we put some contrast, a methylene blue. Sigue, sigue, sigue. Now we're beginning to see some distension. We had an issue, maybe kinking or maybe something, with until the nurse, Almudena, injected and unblocked it, we could not get any distension. That was the reason why. Now she had to press very forcefully, and we get this nicely distended segment of small bowel. We can go back to EUS. Vamos a
Very nice view.
Now we have EUS. El de 20, lo abrimos, lo mojamos. Vamos, ponemos la bomba. Esto es azul con contraste. So, we had one little difficulty, not very, difficult to understand, but the nasobiliary drain was somehow blocked or kinked. While I was stepping on the pump pedal, no fluid was going into the small bowel. That's the reason why we couldn't get a target. Now that it is unblocked by the forceful injection done by Almudena, I have my target right in front of me. There are some bubbles. Ha entrado aire, ¿no? Ha entrado aire, okay? Okay, some air is coming from the pump, so I'm not going to inject. My Axios catheter is going. Takao, do you like the position this loop is standing at the moment?
Not bad.
Not bad.
Mm.
How do you like that one?
Yeah, much better.
Much better. Okay.
Much better.
My catheter is coming from the right side. I want to see the water boil. At the count of 3, I'm going to zoom in on the ultrasound. 1, 2, 3. I want to see the water boil. Did you see the water boil or not? You saw
Yes.
it, right? It was. So I know I'm deep in. I keep pushing, but without stepping on the cautery. I lock the gray button, and then I'm ready to deploy. The flange is going to come backwards towards me, but I'm deeply in. You see the flange? Now I'm pulling back to do intrachannel stent release. So I've done step number 1, step number 2. This pushback is step number 3. Do you like it there, Takao, or is it okay?
Yeah, okay. Nice.
Okay, so I lock, and I'm ready to go step number 4 on the proximal flange. And then I will switch to endoscopy. So I deploy, the only thing you notice during step 4 is that the distal flange stays on target without moving. I've already deployed inside the channel, and I'm going to shift to end of view to show you step number 5, which is basically pushing the proximal flange out from the scope working channel. For that, I unlock the lower button, and then I push the gray part of the catheter while my elevator is down, my insufflation is on, and my echo endoscope is being pulled backward. I'm pushing black catheter, elevator down, pulling back, rotating, and then you see the methylene blue comes here. So there is no concern whatsoever of peritoneal misplacement for 2 reasons. First, we saw the distal tip of the hot Axios catheter boil the water in the jejunum. So we saw those bubbles. There's no missing. We saw under ultrasound the distal flange being deployed inside that loop. And third, we saw the methylene blue flowing backwards. If there's any doubt, you remember the gray color nasobiliary drain? Can you see at the bottom of my Axios tip? So this is intraluminal. And now to finish, before we conclude, maybe Ramon, we can show the X-ray. So I'm going to step on the fluoro. You see now contrast is flowing back into the stomach. This is painting the folds of the stomach. We can go back to endoscopy, Ramon. Vamos a endoscopia. I'm going to pull out the nasobiliary drain catheter. You see the methylene blue here, proximal flange, and that's it. I don't know if there are any questions or comments or.
Fantastic. Very, very, very nice demonstration. Excellent, Manolo.
So we have a little bit of a stricture here at the apex,
Yeah.
but not terrible. And then we have another one just distal to the papilla.
Yes.
in the third duodenum that we could see much better with the side view, with the semi-oblique forward viewing of the echo endoscope, linear echo endoscope, is a little bit more tangential. And as for the position of the axial stent in the stomach, you see it's lying mid-body, body to fundus junction, right? So it's lying, this is the usual typical location. And we will let these 20 millimeter axios to expand gradually over the course of a few hours. And we are done. So I'm going to remove the echo endoscope.
Fantastic, fantastic. So, Manolo, there is a question. What is the advantage of an OSS over a Fogarty catheter? Can you hear me? What is the advantage of an OSS versus Fogarty catheter for advancing the wire?
Catheter?
Yeah.
Maybe while they move the patient in the room, I can take the microphone somewhere else so we have less background noise.
Sure, sure, sure.
And we don't interfere with the personnel, right?
Yeah.
Ramón, ¿podemos llevarnos el micrófono a otro sitio para no molestar aquí? Sí, hemos terminado. A la puerta. A la puerta. Vale, pues a la puerta.
No mucho porque...
Bueno, pues ya vamos a...
Takao. In the meanwhile, there is a question: do patients develop severe diarrhea and malnutrition post EUS-GE?
I've never experienced that, but after injection, a lot of water was herring. Maybe it causes severe diarrhea or something.
Okay.
Yeah. Overhydration.
Okay. There's a question for me. Have you done a benign case? I have done one. It didn't go well. The patient came back pretty soon.
Oh, really?
Yeah. Then can we use a single balloon? Takao again. Instead of a 2 balloons, can we use a 1 balloon which occludes the lumen distally?
Yeah. So I experienced a single balloon, but as I mentioned, a lot of water easily go back stomach, and not so fully occluded. Fully occluded and
you scared me, Takao, with the water.
Yeah. minimum amount of saline is much better for the patient. Just 100 cc or something. Sometimes just ENBD tube pumping or needs a lot of water.
No, the volume that we need to inject is not so big. It's 200 cc. So currently we are doing a prospective study of this EUS-GE technique. We're measuring all the technical, like the volume that we inject, the time it takes for each step, if a trainee can do it, all of that. And this is a multi-center prospective Spanish trial. So far, the mean volume is 200 cc. The problem with our pump today, it is because of this, you know, when you're doing things at a live demo, you may not be paying attention to every step. Our catheter was kink. I was stepping on the pump pedal, but the water was not going through into the small bowel. Then Dr. Itoi said, you have a lot of water in the stomach. And I said, oh, maybe my catheter slipped back into the stomach or something. Luckily, it wasn't like that. The stricture was very tight. So there was no reflux of saline or methylene blue because we didn't see any methylene blue backward into the stomach until after the axios was opened. So all the fluid that we could see during the initial steps of the EUS was the bile that was originally already there when we started. But obviously the reflux of fluid into the stomach is a concern. And as it is the gastric retained contents for this procedure.
Manolo, Lateral position or prone position or supine position?
We use semi-prone, left lateral semi-prone. So like the old ERCP, the left arm is on the patient's back and the patient is a little bit prone, but not fully flat on their bellies.
You're getting a lot of congratulations on a fantastic demonstration. Lots of congratulations are coming as comments. Very, very nice.
Thank you. We appreciate that from Valladolid and all the team that stayed on a Friday afternoon after hours. As I said, Vinay, they're all very happy, provided they are invited to go to Mumbai for next.
Please come, please come.
The nurses too.
One interesting question I want all of you to answer before we go. Diabetic gastroparesis, is it a good indication? Let's start with Mouen. Mouen?
No gastroparesis is a good indication. Please do not do this procedure for gastroparesis. So surgical GJ or any type of stent, it's not, gastroparesis is a very complex entity. You know, it's not just a purely emptying entity. There is a subset of gastroparetic patients whose pylorospasm is a major component, and some of these patients may respond to a surgical procedure like pyloroplasty or GPOM. Maybe a GJ will benefit some of these patients, but we don't have a way to diagnose pylorospasm. So at this time, a GJ should not be considered for gastroparesis.
Okay. Any other opinion, Manolo? You agree?
We don't have a lot of experience in gastroparesis. Mouen has plenty of experience. I know that Michel Barthé has been doing some animal lab experiments on diabetes and gastric emptying.
Okay.
So he and I would probably agree with Mouen. If you do that, do it on a pig. Don't do it on a human.
Okay. Anthony, is ascites a contraindication?
What?
Is ascites a contraindication?
I think it depends on how bad the
If a patient has ascites, would you do a GJ?
So it depends on the quantity. So if there's a lot of ascites, then I would tend to drain them first because there's a risk of infecting the acidic fluid. If it's not a lot, if it's not in the way of the EUS, then I think with small amount of ascites is still okay.
Okay. Takao,
So Vinay, I have a question for Anthony.
Yeah, Manolo.
Anthony,
Okay.
what is that? Is that the panic room in your house, or where are you, Anthony?
I'm in my room that my son studies and does the homework.
It's a kid-proof. It's a kid-proof room, right?
Yeah. Well, they're sleeping.
Last
11.
Last question before we go. We are really late. You have to go, you guys. Takao, it's very late in the evening. I know there. Is there a risk of bleeding secondary to LAMS? If yes, what is the percentage? I mean, for GJ, I guess that is the question.
So basically, in my personal experience is 0. So unless we dilate stent immediately after placement, maybe no such kind of severe bleeding. Okay. Otherwise, of course, usually we have to check the intervening blood vessel before performing this procedure. If so, no problem. Yeah.
Okay, I think we have had a fantastic 3.5 hours discussion on EUS-GE. That's quite comprehensive. Thanks all of you, Manolo, Takao, Anthony, Mouen. Thank you for sparing the time. The registration was almost 800. So that is very, very good. 52 countries. So I think the next webinar will be done by Anthony. So all of you who are there, please attend the next one. Big thanks to Olympus, big thanks to Boston Scientific, big thanks to Jason, Flora, Arun, Olympus guys. Great work, fantastic work, and big thanks to Manolo's team who made the live possible despite difficulties. Great job, great job. Thank you very much. The nurses
Thank
there.
you.
Let's hope we meet soon and these things get over. Thank you very much. Thank you. Bye. Bye.
Congratulations, Vinay.
Yeah.
Thank you. Thank you.
Congratulations, Vinay.
Congrats. The next webinar by AEG will be on US biliary drainage. It's on the 11th of July. So some of you will be faculties to that workshop as well. So thank you.
Yeah.
Thank you. Thank you.
Okay. Bye-bye.
Bye.
Bye.
Thank you. Bye-bye.
Bye, Flora. Thank you.
Thank you very much.
Thank you.
Thanks, Jason.
Thank
Thanks,
you.
Lazaro.
Bye-bye.
Thank you very much. Thank
Good
you.
night. Good night.
Thanks,
Good night.
Vinay.
For the invitation,
Good night.
please.
Good-
Thank you.
Okay. Bye. Thanks, Lazaro. Bye.
Bye.
Thanks, Dixon. Thank you. Thank you very much.
Flora, thank you.
You're welcome. Thank you for your time.
I'm going to write to you later. Thank you.
Thank you.
Okay. Bye.
Bye-bye.
Bye-bye. Có tôi有冇啲咩要課啊？ Oh, Aaron, thanks for joining.
Thank you so much.
Let's have a good rest today.